Hi, everyone. I think we're going to get started. My name is Stacy Sterling, and I'm one of the moderators of this session, and I'm also giving the first talk. And so good morning, everyone. Great to see everyone back. I am from Kaiser Permanente, Northern California, Division of Research, and where I'm a research scientist and also the co-director of the Center for Addiction and Mental Health Research there. And I am delighted to be talking today about our experience implementing SBIRT, screening, brief intervention, and referral to treatment, in adult primary care. And this is going to be, as some people said yesterday, data-free, really just getting into sort of the nuts and bolts of how we implemented SBIRT, including, down to sort of materials and scripts and so forth that we used. And I hope that I can push back gently a little bit on some of the skeptics who say that we can't or shouldn't do this in primary care. So, and again, this is in primary care. It's not dealing specifically with an ALD population, but I think some of the lessons, I hope that some of the lessons can apply to other specialty care settings. So for those of you who aren't familiar with Kaiser Permanente, Northern California, we're a very large integrated healthcare system with 4.6 million members. We cover, insure about a third of the population of Northern California. We're very diverse in many different ways, geographically, sociodemographically. And we are a carved-in system, so we have direct access to addiction medicine and psychiatry. So that is certainly an advantage that we have. We are not monolithic, though, and I will show you that how that has played out in a bit. So our experience with SBIRT, we in mid-2013, we implemented SBIRT in our system, and this was based on work that we had done, a pragmatic trial led by Jennifer Mertens that tested different ways of delivering SBIRT. So who were the best people to do the screening? Who were the best people to actually deliver brief interventions and referral to treatment? And based on just preliminary findings from that, the system agreed to implement SBIRT across our entire region, which we've done. So we have 10 years worth of data that we can look at. And in our, we ended up using sort of a hybrid of the models that we were testing in that trial. So medical assistants do the screening as patients are being roomed. And then if somebody screens positive, the primary care physician delivers the brief intervention and the referral to treatment. So in the past 10 years, we have and numbers are slightly different now, but we've conducted almost 19 million screenings. 1.2 million brief interventions have been delivered. It's been a very successful program. So I'm going to talk about some of the factors that we have found in our experience to be associated with, or that we have found to be very helpful, and things that we did. So first of all, leadership support, and I mean leadership support at every single level. So from executive leadership support, our executive medical director actually filmed a video to encourage fellow physicians to participate in screening and brief intervention, that alcohol was an important problem, that it causes a lot of health problems and it's very costly, down to clinical leadership at the clinic level. So really involving people at every single level of leadership. Multidisciplinary stakeholders. So we, particularly in the beginning, we brought together people from addiction medicine, from primary care, obviously, from psychiatry, from research, to be part of the team to push forward this initiative. Implementation, facilitation, and technical assistance. We heard about that, a lot about that yesterday, and that was really critical, particularly in the beginning. So helping teams really work through, how do I ask this? How do we fit this into our workflow? How do I make a referral to addiction medicine if somebody needs additional treatment and so forth? So our implementation facilitator would go out to huddles and traveled around the region and would meet with teams as they were trying to implement this really throughout the first year of implementation. Excuse me for my voice. My daughter gave me this gift. We established a team at every medical center. So we had an alcohol education champion who was a primary care physician. And then we had an addiction medicine specialist. And they became the point people for their colleagues. They were the people that people could go to ask, oh, how do I do this? I got a referral from primary care. What do I, how do I respond? And we really encouraged that relationship because very often they had never met one another. So we would encourage them to get coffee, or, we would send them little emails, hi, here's Dr. So-and-so, here's Dr. So-and-so, why don't you guys get together? And then the electronic health record. And we heard some talk about whether they can be used for this purpose. And I've had a lot of talks with Kathy about how screening should be conducted. And I totally agree with her that really it should be done where patients self-report in a somewhat confidential way, don't have to have anybody asking them the questions. But for us at the time, being able to get the questions into the EHR made it part of the DNA of the workflow in the clinic. And I think it really enabled this initiative to go forward. So I'm going to show you some examples of that. So this is when the medical assistant is rooming a patient. Patient comes in, we were able to just serendipitously get alcohol questions right there next to your blood pressure and your weight and smoking, and whether you were up to date on your cancer screening and so forth. And that was just key because that was the first time that alcohol was, considered on par with those other important things that we're measuring. And so that's really been a huge thing. And this reminds the MA to go ahead and do the screening. Here are the questions. We didn't, excuse me, we didn't use the audit C. We used the NIAAA single item screening question with the 2 follow-up questions, which allowed us to have a picture of not only their daily binge drinking, but also weekly consumption. And then the EHR calculates their weekly number of drinks. And these were tailored to sex and age at the time. And then this clinical decision support is provided to the primary care physician. So this tells you how somebody has, whether they have screened positive, what their answers were. It suggests if they want to follow up with some additional assessment, it provides the Vincent 2-item screener for dependence risk. And it suggests that they provide brief advice to cut back and how to code the brief intervention. So some of the other factors that we found, so training on the intervention. We trained all of the physicians. We used to train the trainers model. So we brought, the curriculum was based on work that Rich Sates and Dan Alford had developed, and we brought them out actually to California to train all of the trainers. And then those alcohol education champions trained their colleagues at every medical center. And we also trained the medical assistants. So we did a really broad ranging all across the region, training medical assistants on how to do the screening and how to, because some of them were very uncomfortable with screening. I don't want to ask people about their alcohol. These are awkward questions, but we really made it, we tried to, a big part of our thrust has been normalizing conversations about alcohol use. We also developed a slew of marketing and communications tools that are provider-facing, MA-facing, patient-facing that we use all the time. Performance feedback was a huge part of of this work, and I'll show you some examples of that. But how are medical centers doing? How are physicians doing? How are MAs doing in terms of these activities? And that, of course, requires timely access to data. And so we worked really closely with our team in the health system to provide monthly, in the beginning, monthly performance data on screening and on brief intervention. So this is not for your benefit. I know you know this, but this is an example of some of the messaging that we would use with physicians. So, explaining to them why it's so important, how it's related to health conditions, things that we know, how costly it is. That really resonates with health system leaders. That it can be cost effective, although Jeremy, I know you, we've talked about this, whether that's actually the case. But we know that a lot, especially 10 years ago, that a lot of our primary care teams were not thinking about alcohol in this way. This is the rankings of the National Commission on Prevention Priorities. That's proven to be very compelling to our physicians time and again, seeing how highly it's ranked based on clinically preventable burden and cost effectiveness, higher than things that we do all the time in primary care. So we would never, hypertension screening, we would never say that we don't have time to follow up on hypertension screening and talk to our patient about that, right? But we can say that about alcohol. So I think trying to, help rejigger people's thinking about what are high priority activities that we should be doing. We also, early on, we thought we were going to train all the doctors to do motivational interviewing, and we're quickly disabused of that idea because nobody has time, right? So we kind of settled on a brief advice approach, and that was palatable to them. It was very much grounded in tying it to their presenting health problems. So if somebody, this could affect your sleep, you're having a problem sleeping, why don't you, cut back, why don't you try going from 2 glasses of wine to 1 glass of wine a night, right? And come back in a month or so and let's see how that's going, or, whatever it is. And so, and that is something that they felt they could get their arms around. So giving them specific scripts and making sure that they understood what the low risk drinking limits are. Just one example of the medical assistant training, wanting to make sure not only are they not saying, oh, you're not drinking, honey, but so that they're not asking the question in this way: in the past 3 months, have you had 5 or more drinks? Because we know that that allows people to say no, if generally they don't do that. But yeah, actually on New Year's Eve, I did do that. So the correct way to say it is, how many times in the past 3 months have you had 5 or more drinks in a day? And that really normalizes that, sometimes people do that. And so really, again, really specific training for the MAs and for the physicians. We created these signs that were in every exam room at one time. And that had several purposes. We really wanted to normalize asking patients about their drinking. We wanted to let people know that we ask everyone, so that people didn't feel singled out because I'm, whatever. And also, it's a way to educate people, something for patients to look at while they're waiting for their doctor, something to stimulate the conversation, because we know that people don't really know what drinks, standard drink sizes are. So these were in every exam room. We also created these and translated all of the materials in this program to all, the major languages. We don't cover everything, but Spanish, Chinese, Vietnamese, the languages that are spoken by our membership, and not just these standard drink, but, rethinking drinking, we translated, all of those materials, the scripts as well. So performance measurement. So this is an example. Medical assistants meet with their MA managers once a month, and they get, scored on all of these different things that they're supposed to be doing with patients. And so making sure that alcohol screening got onto that card so that the managers could talk to the MAs about it and what their screening, how their screening rates were. This is an example of the monthly reports that we sent to the medical center, the chief of of medicine at every medical center. We sent these out and also sent it to executive leadership. And, you doctors are inherently very, want to be A students. And, and so, creating a little bit of competition so we could see like, why is, what's going on with site D? Why are they so low, and how can they get up? But you see there's a lot of variation here. Similarly, we sent these are all blocked out, but these are individual provider scores, brief intervention rates at every clinic. And these were sent to the chief in that clinic, again, to sort of spur a little bit of competition. And they told us they would often use these unblinded in their module meetings to say, hey, Stacy, why are you at 0 brief intervention rate? And can you work with, Murtaza, who's at 100%, and maybe he can, help coach you on how to deliver brief interventions and work it into your workflow. So, but again, you can see there's still a lot of variability across our sites. Some of the sites are brief intervention rates are below 30% and some are up above 80%. So this provided a really nice natural experiment for this next study that I'm going to talk about. And I'm not going to get too deeply into the methods here, but this is a study that I've been conducting, and we're using the PRISM implementation framework. Some of you might be familiar with that. It's an implementation research framework. And it sort of divides factors into these different large domain areas. So we have external environmental factors, which are things like policy and HEDIS measures and, parity legislation and so forth. The program intervention, those really relate to the intervention itself and how well it fits into workflows and provider confidence in the effectiveness of the intervention. Implementation infrastructure, so does an organization or a setting have the infrastructure to implement things and sustain them? And then recipients, and that's both the people who are going to be using the intervention and the patients who will be receiving it. So we've looked at, we've used EHR data to look at screening and brief intervention rates for over 8 years. And we've also conducted a physician survey of almost 800 physicians to get a sense of their assessment of all of these factors at their facility. And our survey drew from these instruments that some of you might be familiar with that really sort of measure institutional capacity and these things. So the ORIC and the ORCA and so forth. And we generated PRISM domain summary scores for each facility based on that PCP survey. So you'll see these are our screening and brief intervention rates over 8 years. And they follow a very similar pattern. You see that drop in 2020 with the pandemic, but we've had very good screening rates. Generally, for the most part, up above 90%. Our brief intervention rates are somewhat lower, but but still good relative to a lot of other settings. Yeah, so we've been very happy. It's been a very successful program. So what we found after adjusting for patient panel characteristics across all of these settings, we found that facilities with higher infrastructure capacity scores, indicating more robust innovation implementation capacity, had higher screening and brief intervention rates over time. That facilities with higher program intervention scores, according to the PRISM, indicating positive perceptions of SBIRT evidence and feasibility and fit into clinical practice had higher screening rates. And facilities with higher recipient scores indicating either organizational support and management support and greater perceived patient needs and likely benefit from SBIRT had higher brief intervention rates. Because infrastructure capacity seemed to be the most robust predictor, we looked at over time, what happened in terms of low and high performing. And you see in the blue, these are higher performing sites with higher infrastructure capacity scores. The red is lower, or the orange is lower scores on that. And you see they started out together, and then they really diverged, and they never came back together. So throughout the pandemic and everything else, the higher scoring infrastructure capacity sites did better. So, our experience, both our sort of practical, pragmatic experience, and then also this study really suggests that factors that facilitate successful implementation and sustainability have to do with organizational structures that support implementation. That seems sort of intuitive. So what do we do with this? I would say that before embarking on implementation, you should really conduct a really careful assessment of implementation capacity prior to implementation. So how is an organization set on in all of these types of factors? If you see weaknesses, then what can you do to scaffold that infrastructure to lay the groundwork for successful implementation and sustainment? Providing practice facilitation, I think, is really key, and coaching and technical assistance, particularly in the early stages. Priming management and clinical teams with training to enhance their confidence in the effectiveness of SBIRT and the feasibility of SBIRT. Obviously the feasibility, because I know a lot of people are skeptical about whether it can actually be done. And I believe that it can be, but we have to convince people that it can be. Training, which really emphasizes the normalization of discussions about alcohol. So these are not these stigmatized, kind of shameful things that we talk about, behind closed doors, but something that we talk about just like we talk about weight and exercise and smoking and everything else that you talk to your doctor about. We ask everyone. And that obviously involves destigmatization. And then, making the link in providers and patients' minds between their health problems, their needs for well-being and wellness, and SBIRT's benefits. And then finally, not waiting to intervene and thinking that, a poor performing site will get better. Intervene early because it's likely not to get better without support. So I will stop there. Thank you. Yeah.
Introduce Dr. Sengupta first. Dr. Sengupta is an assistant professor at Cleveland Clinic in transplant hepatology. She has an interest clinically in ALD and research-wise in ALD as well, and harm reduction. She devised and implemented a multidisciplinary clinic at Cleveland Clinic as well for ALD that spans the transplant continuum. And so she'll be talking with us about kind of some of the real world lessons she learned, kind of a case study about from the ground up how to do this in a healthcare system. So thanks, Mom.
Good morning. Thanks for the introduction, Jess. I want to thank Doctors Shaw, Wang, and Young and the NIAAA for sponsoring this event and for inviting me to speak today. So in terms of data, not heavy talks, this talk has no data. This is just based on my experience, discussions with others who are doing great work in the field of integrated ALD care, like Drs. Mellinger, Drs. Fernandez, Drs. Winder. So during the first part, I'll cover suggested implementation milestones for establishing an integrated ALD clinic. The second part will detail my personal experience in setting up the clinic at the Cleveland Clinic. And then finally, I'll conclude with key recommendations. So the thought of starting a clinic is a little bit overwhelming. So I was thinking of what were the steps that I took and, sort of what resources did I use? And so here are some suggested sort of steps to follow if you're thinking about integrating, starting an integrated ALD clinic. So first and foremost, you really have to understand the structure of your organization. Second, you should figure out how to appropriately position the ALD clinic within your organization. Number 3, identify key team members, define appropriate inclusion criteria, the boring stuff, complete logistical tasks related to clinic operations, also the most time-intensive part. Promote the clinic through appropriate marketing. Start seeing patients, start adjusting your workflow, and then once the clinic has started, literally like once it's launched, start preparing for expansion and change because it's coming. So like I said, the first step is to understand the organizational structure of the health system you're in. So, I've included a couple examples of different structures. On the left is a traditional academic medical center. This is modeled after University of Michigan. On the right, you'll see an example of an institute-based center, which is modeled after the Cleveland Clinic. I know there are many other organizational structures out there. These are just the two I had familiarity with, and so I provided these for examples. As you can see, with either organization structure, you're going to need providers from multiple departments or institutes to fully staff an integrated ALD clinic with all necessary personnel. It's not just going to come from one department. In addition to understanding organizational structure and hierarchies, it's also important to identify existing relationships between hepatology, the transplant center, and mental health providers. So things I had to figure out were like, does a hepatologist report to a chair of gastroenterology or right to the transplant director of the transplant center? Where are social workers hired? Are they hired through the transplant center, through a different institute? Are psychiatry, psychology, and social work even in the same department, or do they have different leadership? So understanding mutual leadership, shared resources, and the flow of finances related to each provider's work is really important when you're making a sound, patient-centered, and financial case for an integrated care clinic, because you will ultimately have to make a financial case. Whether or not a health system is research or clinically driven also matters when you're, sort of tailoring this, when you're building this clinic. So for a research-driven organization, focusing on the potential research implications of an integrated care clinic will be very compelling, while a clinically driven system is going to focus more on revenue generation, utilization of existing and shared resources. Gaining leadership buy-in early is critical, and really, without the right tailored pitch, you're not going to get this off the ground. So determining, the appropriate positioning of the clinic within the organization, you have to understand the same hierarchies, dynamics, alignment in terms of patient population of interest, financial incentives. So, I would suggest positioning the integrated ALD clinic within the section of hepatology or the liver transplant center. There are pros and cons of either placement. So if you position the ALD clinic within the section of hepatology, this allows you to focus on non-transplant patients. You can develop partnership with addiction-specific providers who haven't really historically been part of the liver transplant team. You can create new interprofessional teams which link departments with many mutual patients. And it gives you a little bit of autonomy from the transplant program requirements or expectations that they may have in management of patients with ALD. Cons of placement within hepatology are that clinic staff are from different departments. They have different leadership and they may not have aligned clinical care goals, and they may not be able to really equally invest in a multidisciplinary clinic. Positioning the ALD clinic within the liver transplant center allows for utilization of providers such as transplant social work, transplant psychiatry, who are already experienced in conducting psychosocial assessments in patients with hepatic encephalopathy and who are used to managing a very medically ill population. Providers from the transplant center are also well-versed in multidisciplinary care for complex patients. And placing the ALD clinic within the transplant center also allows for continuity in care for patients who are referred and ultimately undergo liver transplant. Cons of placement within the liver transplant center are reliance on providers with large caseloads. The transplant volumes are growing, the post-transplant patients are there for life, and on providers who really may not have addiction-specific training. However, where the clinic is positioned is ultimately a personalized decision for each center based on organization structure, resource availability, and team dynamics. So once you've identified organizational dynamics, you figured out where you're going to position the clinic, identification of key team members is the next step. And for me, it's been one of the most important in ensuring the long-term success of an integrated ALD clinic. So identifying providers with pre-existing relationships is great. Cultivating new relationships through shared decision-making, in which all team members are equal stakeholders. This shouldn't just be one person. Everybody should be equally invested in this clinic. Interprofessional education and staff training, and regular clinic business meetings, that weekly huddle that Dr. Serper was talking about a lot. They're really important for team building and for the clinic to function appropriately. We suggest seeking out potential collaborators in the mental health and substance use fields broadly. So look at your addiction psychiatrists and psychologists, CL psych, transplant psych and psychology, addiction medicine, social work. While it's ideal to have mental health partners who can prescribe medications, when you're initially building an ALD clinic, you should cast a wide net, and any interested party from mental health or substance use disorder treatment should be welcomed and incorporated into the clinic as possible. When possible, have backup providers identified, to accommodate vacation, service, sick days, medical leave, and try to minimize interruptions to the clinic. Clear inclusion criteria are important to ensure access for a medically ill ALD population and really avoid patients with mild liver disease who really don't need to see a hepatologist, or those who have a primary non-alcohol substance use disorder. Doctors Winder and Mellinger and Fernandez have written on this, published about this with their early experience as well. Logistical tasks related to clinic operations should focus on appropriate credentialing and billing, preparing the electronic health record, creating new contexts and departments. I would say creating templated notes to allow for ease in population of health management and data tracking has been very helpful. And finding an ideal physical space which can accommodate medically ill ALD patients while being conducive to psychiatric care. So your clinic space should be large enough to accommodate a wheelchair. There should be beds that lay flat and that lower to the ground, and you really should have access to emergency services. Marketing and promotion of the integrated ALD clinic should start with the departments which house hepatology and addiction medicine. We found that early education to residents and fellows will help promote the clinic to other physicians within the medical system. And then really getting to hospital medicine, primary care, satellite clinics, satellite hospital sites. For us, we have a lot of affiliated GI practices. So focusing on educational opportunities that offer CME is important for sort of getting the word out there. We have a robust marketing team at our hospital system. They've been great in terms of internal advertising. It's also allowed for some engagement with the local media. I will say you should really exhaust sources of internal referrals. There are many, and you should have many backup providers in place before expanding to external referrals. Once the clinic is up and running, we recommend, sort of adopting a continuous improvement mindset in terms of workflow, referrals, and personnel. This helps set the stage for the inevitable need to adapt and hopefully expand clinic operations. Establishing and sustaining an integrated ALD clinic requires adaptability to accommodate growing referral volumes, care of established patients, expansion of clinic operating times and sites, and changes in staff due to natural turnover in medical centers. During the second part, I'll talk about sort of my personal experience at the Cleveland Clinic. And so on this slide, you'll see a timeline for establishing our integrated ALD clinic, which is called the Multidisciplinary ALD Program, or MAP clinic for short. I want to thank Drs. Mellinger, Fernandez, and Winder for really creating a blueprint for how to set this up. My job was so much easier because you guys had already done it. And for really writing about the processes and early successes so I could point to that to my department chair to say, hey, look, this works. For us, the process took about a year. We decided to position the clinic within the section of hepatology, honestly, because I had leadership support from my Department of GI chair. He was the department chair, had recently been named the institute chair, and had extensive experience with a medical home model in the field of IBD. So very, very receptive ears to my initial pitch. Really, there was some luck involved in how easy that first sort of pitch was. Because we positioned ourselves outside of the liver transplant program, I sought collaborators in the non-transplant space, and it, eventually was introduced to an addiction psychiatrist who had also trained at Michigan and was passionate about an integrated care model. After this, we identified key team members, including my nurse, who's a care coordinator from hepatology, and a licensed independent social worker who had worked with our addiction psychiatrist for nearly 10 years with a background in chemical dependency. This step is really important. We were really lucky to recruit staff who we had worked with closely for years, and this has been really important as we've been growing and expanding the clinic. From there on out, in November, we presented the idea to the psychiatry chair. In December, we got approval from both institutes. In January of 2022, we met with really the key mental and behavioral health stakeholders within our institution. We really wanted to share and hear ideas. So we met with transplant psych, social work, GI behavioral psychology, and we wanted to really make sure that our clinic was inclusive from the beginning. Anybody who wanted to be part of it was welcome to be. In February of 2022, we began planning clinical operations, which took months between credentialing, electronic health record preparation, billing. In May of 2022, we launched the clinic and saw one patient, and then realized there had been an error in credentialing for our social worker. And then finally, in June of 2022, we officially launched, and a few months later, we updated and expanded our inclusion criteria. So why did we expand our inclusion criteria? One, we really needed to make the clinic more sustainable. There had been very little promotion, no word of mouth, and really our clinic was not visible. Our initial referral volume was low. We even had limited internal referrals from colleagues within hepatology, who are a little bit wary to refer their patients to a new program. We had also excluded patients who were being evaluated for liver transplant. That was intentional in our inclusion criteria. So we really weren't getting the high acuity patients with ALD and active alcohol use who really needed multimodal care. Secondly, as many programs probably did, we noted increased rates of post-transplant alcohol use in our liver transplant program, and found honestly that our program was struggling to provide addiction care to so many patients at once. And so we made a strategic decision to partner with the liver transplant program and formally accept post-transplant patients who'd been transplanted for ALD and who had, experienced a return to alcohol use. And this allowed us to form alliances with a large and powerful program and build trust and really become somewhat indispensable through the care of a complex and challenging patient population. So here are our inclusion criteria, which were modeled after the Michigan main clinic, but expanded to include the post-transplant population and patients who were ineligible for liver transplant upon initial evaluation. This expansion helped us create a patient population, of interest to us, but more importantly, allowed a population in need of coordinated addiction and medical care to get to us. Some of these you'll notice, resident of Ohio has been one of our inclusion criteria. A lot of that was largely based on our social workers licensure, and that's going to change, I think, as telehealth becomes more predominant in the field of behavioral medicine. So hopefully that will not always be part of the criteria. So we've been fortunate to have early success in the MAP clinic. I attribute a lot of that to our great team who have a very aligned work ethic, are very interested in cross-training, and who work really at the top of their license while also wearing the hat of a scheduler and a research coordinator and really working and doing a lot of administrative tasks. I think importantly, it sounds cheesy, but clinic is fun. Nobody dreads clinic. Everybody wants to be there. Everyone's equally invested in making it a success, which really makes the experience much nicer for everybody. I looked at our numbers as of yesterday. So from a recruitment perspective, we've gotten 292 referrals. We've evaluated 121 patients, and actually 105 are still followed long-term in our clinic. In January of this year, we created an electronic health record order set, and that's led to about 5 to 7 new referrals per week since we implemented it. We routinely overbook patients, and we've established a cancellation list so that we can fill our available clinic slots every week. As you can see, we've had nearly 300 referrals and have only seen about 120. So there's a large lack of engagement, no-show, in this patient population. We're trying to overcome that by having slots available all the time. So if we even get a window of insight, we can get the patient in, within a week. We've promoted our clinic through grand rounds, case conferences, department meetings, regional site department meetings. I'm sure people are sick of us at this point, but we've also found publicity through the receipt of 3 separate internal grants, all of which were actually publicized on our medical systems intranet homepage. And so that actually helped with some visibility. With our increase in volume has come the expansion in our clinic. So we started by having 1 half day of clinic per week. Now we operate 2 half days per week, and we've expanded the clinic to Lutheran Hospital, which is the primary site for addiction care in the Cleveland Clinic's Northeast Ohio market. We've also partnered with APPs, or advanced practice providers, to continue to grow the clinic and to obtain backup staff for time away and some of the other things I mentioned, so that the clinic can run year-round without interruption. We're working on 2 more ideas for APP-led expansion, one of which is ideally establishing an APP-led long-term management clinic for stable patients. And finally, largely related to our social workers licensure, we're planning to expand to telehealth for return visits once that's complete. One other success that I want to highlight is that, in our clinic, we really work to meet patients where they are. And we're trying to adopt principles related to harm reduction in our practice, as so many of us do. While we know that abstinence is the safest option for patients with advanced liver disease, we also realize that with chronic disease management, which is both ALD and AUD, small steps are better than none, and that without a therapeutic alliance, the patient will disengage and we'll lose them from medical contact. Our clinic has had a positive impact on both the liver transplant program and the section of hepatology. So we used internal grant funding to create a position for a post-transplant social worker and provided salary support for 1 year for our MAP clinic social worker to take on this part-time role. Because we had early success, we were able to formally create a position that just got budget approval from the Institute. And our MAP clinic social worker is now officially the post-transplant social worker for about 50% of the week. There's not enough of her to go around, but we're utilizing her to her maximal capacity. Our clinic staff were also part of a liver transplant program working group to establish a formal post-transplant monitoring protocol for patients who are transplanted for ALD. And really informally, our clinic has become a resource for AUD management for all liver transplant recipients, irrespective of whether they're seen in our clinic. And finally, because of our social worker who's been hired for 50% effort in our clinic, she's able to see patients while they're hospitalized, which allows for continuity of care, or what Dr. DiMartini described as wraparound care in her great talk yesterday. Within the section of hepatology, we found an increase in the number of referrals to our addiction center, an anecdotal increase in MAT prescription rates for all hepatologists. We've also found an increase in the identification and management of outpatient alcohol withdrawal within our hepatology clinic. And there have been new partnerships that have developed between the addiction team and other hepatologists, largely who are interested in treating MASLD. This data is unpublished at this time, but analysis of our data from the first 18 months of clinic has shown a reduction in the rates of monthly ED and inpatient utilization for patients who were seen in MAP clinic, even those who just had 1 visit. We've also found improvements in markers of liver injury, MELD and Child-Turcotte-Pugh scores, Karnofsky Performance Scale scores, PEth levels, reductions in self-reported alcohol use and risk factors, which are measured by the Brief Addiction Monitor and Audit-C. Key findings that have helped us make a financial case for our institution for this integrated clinic are decreased inpatient utilization, optimization of outpatient social work billing, management of provider salaries by partnering with advanced practice providers, an early partnership with the liver transplant group, and then overbooking to ensure fill rates. have a lot of challenges. Some we've overcome and some remain a constant struggle. I mean, I think challenges 1 through 10 are that there are not enough addiction providers. I know I'm echoing a fact that has been stated by many of the speakers, but in the Northeast Ohio market for Cleveland Clinic, which includes 14 hospitals and 20 family health centers, there are 2 addiction psychiatrists and 1 part-time addiction medicine doctor. There are 12 hepatologists in 1 center. So we need more investment in addiction care from our medical system, because as much as we can work 2 people, I think we really have, but there are limits to what they can do. And I think sometimes those of us in the alcohol field forget that there are other substance use disorders that our addiction psychiatrists are also busy treating. That's honestly our biggest challenge. You know, with regards to recruitment, this is not a clinical trial, this is a clinic. And so we had to accept patients outside of our stated inclusion criteria, honestly, to get the clinic off the ground. Early on, this led to some heterogeneity in the patient population, but with our increase in referral volume, I think this has evened out. The length of appointment days and our model of in-person visits has been a detriment to some patients. We hope to change that through virtual visits, you know, through offering some telehealth visits as well. And finally, you know, most people are amenable to seeing a hepatologist, but there's still a considerable amount of resistance to seeing a mental health provider. One challenge related to recruitment that's specific to our institute and maybe, you know, applicable to other health systems too, is centralized scheduling. I never realized how much I would grow to hate centralized scheduling because of this. So we can't train call center employees to screen and refer to our clinic. We just can't. So we miss so many new patient referrals who go to see hepatology, GI, and then some of them ultimately trickle back. But if you're trying to show, hey, new patient evaluations, you know, I'm not getting as many because of centralized scheduling, to be perfectly honest. The other thing is that our patient population requires multiple points of contact. We once called a patient 18 times to get them scheduled because of missed phone calls, hospitalizations, paracentesis, IOP. Central scheduling calls the patient once and leaves a voicemail. That's it. One of the most unexpected challenges we've faced is related to Title 42 of Part 2 of the Code of Federal Regulations, which actually regulates the confidentiality of substance use disorder patient records. Because we partnered with addiction-specific providers who are part of a federal program that treats substance use disorder, our medical records were locked down. So nobody could see our records. So we had to work with the Cleveland Clinic legal team to make my records visible, because the argument was that if a patient ended up in the ER and couldn't see the records or ended up elsewhere, that was detrimental to care. So now my records are unlocked, but this has been a large headache. Finally, just some key recommendations for establishing a clinic based on my experience. So number 1, obtain leadership support by delivering a tailored pitch for your health system. Number 2, position the ALD clinic in an optimal organizational location with visibility, resources, and support. Number 3, pick the right team. Interprofessional relationships and team dynamics are paramount. Number 4, define clear inclusion criteria and ensure access for medically ill patients with AUD. And finally, be prepared for change and expansion, partner with advanced practice providers, and use telehealth to expand access where possible. Thank you.
Wow, that was great. Come on up. So I'm happy to introduce Dr. Mandala Khalili. She's a professor of medicine at, do you want to make sure you get your, close that out, I think. She's a professor of medicine at UC San Francisco and the director of clinical and translational research in hepatology and the chief of clinical hepatology at San Francisco General. And her research focuses on addressing health disparities in liver disease, including among those with unhealthy alcohol use through epidemiology and natural history studies, novel therapies, health services research, and implementation science. And I think you're going to be building on some of what we began to hear from Derek Satre yesterday. So yay.
Thank you very much, Stacy, for that kind introduction. And I'd like to thank the organizers for the opportunity to present at this very important meeting. Well, being this second last talk of the day, I have to say much of the statistics have already been presented. But as you all know, there's a race, age, and sex disparities in both prevalence and also adverse outcomes of alcohol-associated liver disease, as shown in this figure. And following the pandemic, these disparities have further widened in that there's been a highest rate of increase in acute alcoholic hepatitis hospital admissions and thereby increase in ALD mortality in women and young individuals and vulnerable populations, those individuals with socioeconomic disadvantage, medically disadvantaged groups, those with large proportion of mental health illnesses, and also minority populations are disproportionately affected. The ALD, or alcohol-associated liver disease, is currently the highest indication for end-stage liver disease admissions at safety net hospitals. Similarly, we've shown that veterans are especially susceptible to increased alcohol consumption as well. In the third year following the pandemic, 1 in 7 veterans reported highest alcohol use, and this was especially prevalent among those individuals at the ages of 18 to 39, which really emphasizes not only the need for awareness, but also regular assessment, timely treatment of this population at risk. When focusing on minority health and health disparities, it's really important to think about the mechanisms involved in this promotion of disparities. And as shown in this figure, these interactions are complex and multifaceted and span several domains. That includes biological, behavioral, physical built environment, social cultural environment, and healthcare systems, and involve levels of influence that spans individual levels or factors, including social demographic issues, health literacy, cultural identity, interpersonal factors such as stigma that's been mentioned several times to now, social support, and preferences in addiction treatments, community factors such as sober community support, structural discrimination, and perceptions of abuse. And at the same time as well, social factors like Medicaid policies. And when thinking about these factors, a better understanding of their interplay really creates an opportunity for us to better understand how to implement shared services within either liver care or alcohol abuse disorder. And with that in mind, novel approaches such as telehealth really pose a particular approach that may have a potential in addressing these issues and providing solutions. So telehealth to date in the liver world has been very successful in treating patients with hepatitis C. It's been important recently in increasing access to liver specialty care in patients with advanced liver disease or cirrhosis. It can enhance lifestyle modifications and improving weight loss, for example, in the setting of fatty liver disease, and has been used in monitoring patients following liver transplantation. In the setting of unhealthy alcohol use, it has been shown to reduce alcohol consumption. It improves accessibility, it enhances quality of life, reduces treatment costs, increases implementation of coping skill, and thereby motivation for change. But when we think about the many advantages of telehealth, which includes ease of use, low cost, decreased wait times potentially, also potential for improving access and outcomes, enhancing adherence to medications, and decreasing readmissions rates in the hospital, we have to be aware that reliance on digital technologies also can expand or enhance disparities. In that between those individuals who have access, who have the ability or connectivity and the digital literacy to utilize them compared to those who don't, these disparities can expand. In fact, digital literacy, language compatibility, and internet connectivity has now been considered other components of social determinants of health that are interrelated to known components such as income, education, and housing. So when we think about considerations for improved telehealth use in vulnerable populations, we really should center this on equity. You have to be aware of the fact that there may be disproportionate access to care, that there is low or limited health literacy in these populations. There's cultural responses, clinical or cultural perceptions. There's trust in the system that needs to be addressed. We have to encourage and educate patients averse to inpatient or in-person visits to consider telehealth, target support with the use of the telehealth, and also provide options that are different than what is particularly offered, such as over-the-phone visits, even though less applicable or less effective, and also provide cultural or language proficiency. A better understanding of these factors, as well as their intersections with other factors such as age, race, sex, and social determinants are going to be very critical in addressing these gaps. Now, a key component of achieving healthcare equity and patient-centered care that is really important in not only effectiveness, but safety of care delivery and the quality of care is really patient-reported experiences. In a recent study, we explored satisfaction with telehealth while accounting for time since the pandemic. And 220 patients with fatty liver disease. This included both metabolic and alcohol-associated liver disease. The mean age of this cohort was 50 years old, and 2/3 of them were women and Hispanic. We found that while overall 70% of the patients reported either great satisfaction and somewhat satisfaction with the use of telehepatology, Hispanic ethnicity and access or lack of access to personal cell phone and internet connectivity was independently associated with telehepatology satisfaction. And this was after inclusion of other factors, biological factors such as age, sex, and race, as well as other social determinants of health measures, as well as severity of liver disease. We further evaluated factors associated with telehepatology use and also 2 domains of satisfaction. This was not only just with the visit level, but also system level satisfactions for 256 patients with cirrhosis that were surveyed using the telehealth satisfaction and usefulness questionnaire, liver disease quality of life, digital capacity, pandemic stress, alcohol use, and depression, and various types of factors that are interpersonal, individual, community, and society as listed here in this figure among 3 large health systems in the Northern California. This was 2 VA and a safety net health system. A word about telehealth satisfaction and usefulness questionnaire. We chose to use this item. It is a 26-item questionnaire that has both construct validity and internal consistency reliability. It is available both in English and Spanish, which is the larger non-English speaking population in our catchment area. It has a very available or easy readability level of 8th grade, which is good for patients with limited health literacy and limited literacy. It has also a broad range of telehealth services applicability. The participant characteristics are listed here. The mean age was 60, 80% were male, 40% were either white or Spanish. We had 1/4 of the patients that were non-English speaker or that they had lower than high school education. And importantly, more than 50% of these patients had $30,000 or less of annual income, and only 22% had paid employment. As you can see, the most common etiology of cirrhosis was alcohol-related at 45%, and then hepatitis C at 40%. About 35% of these populations were either decompensated in the past or had current decompensation of liver disease. Interestingly, internet capacity was quite high. 100% of these individuals actually had devices, either phone, tablet, or computer. 90% of them were smartphones. They could use these devices in private places, and they could perform or use these devices for more than 4 out of 8 tasks. 75% of these individuals have been exposed to telehepatology within the prior 6 months, and the satisfaction scores for use of the telehealth system was 3.7 out of 5 and 3.8 out of 5 for the telehealth visit itself. When evaluating alcohol use in this population in the prior 12 months, 32% endorsed alcohol use, of whom 19% had risky hazardous use, 7% had harmful use, and 18% had high risk of probable dependence. The mean audit scores was 4, 17% reported change in alcohol use during the pandemic, and 43% reported participating in some sort of substance use treatment in their lifetime. When adjusting for site on multivariable analysis, we saw that alcohol-associated liver disease and alcohol symptoms, or as reflected by higher audit scores, were associated with lower satisfaction with telehepatology or lower satisfaction with telehealth as a whole. Higher pandemic stress was associated with greater telehepatology use, and better quality of life and Latino ethnicity were associated with higher satisfaction with telehealth system and visit. Older age was associated with lower satisfaction with telehealth system. Our study shows that vulnerable populations with cirrhosis had capacity to participate in telehealth or liver care using telehealth modality, but 25% did not. Higher alcohol-related symptoms and alcohol-associated liver disease were associated with lower participation in telehepatology and satisfaction with visits. And vulnerable patients with alcohol-related problems and alcohol-associated liver disease, especially older individuals with poor quality of life, may require tailoring of telehepatology care delivery. And whether these patient-reported experiences influence alcohol treatment delivery using telehealth in this population is currently being studied, as highlighted by Dr. Sattler yesterday. In order for us to really address ALD and alcohol use disorder in a comprehensive way, we have to also think about the promotion of quality of life in these individuals. And this is considered a holistic part of treatment. NIAAA, as been mentioned before, has recently broadened its research definition of AUD recovery to include measurements of biopsychological well-being and quality of life as clinical outcomes. And to the extent to which ALD etiology and problematic drinking are impacting or associated with liver disease quality of life domains remains understudied, especially in the vulnerable populations with advanced liver disease. Among 329 patients with cirrhosis, in collaboration with one of our colleagues at NIAAA, we looked at our hepatology clinics across 3 sites. There are 2 VAs and the safety net healthcare system. And we evaluated associations of alcohol-associated cirrhosis and etiology and problematic drinking with liver disease quality of life measures. This liver disease quality of life has 9 domains. It includes health distress, memory concentration, liver disease symptoms, effects of liver disease, sleep, stigma, sexual function, loneliness, and hopelessness. We found that problematic drinking, which was defined as audit score of greater than or equal to 8, was associated with worse liver disease quality of life, and specifically in the domain of health distress and memory concentration. And both of these actually map into the 2 addiction clinical domains of cognitive dysfunction and depression. These findings can help inform integrated liver disease and behavioral health care in this population, but also help us to understand that in risk identification, especially of those individuals with cognitive dysfunction, is critical in implementing integrated care in this population. So we have shown that throughout the past day and today, that telehealth approaches are quite useful. They can certainly be providing education within a context of liver disease. They can provide treatment access for both individuals with alcohol use disorder and liver complications, induce abstinence in the alcohol disorder setting, prevent relapse, and thereby prevent progression of liver disease. But we have to be careful in understanding that telehealth approaches for vulnerable populations with ALD may benefit from integration of alcohol treatment and liver disease management, but may require tailoring in order to enhance patient satisfaction and in order to achieve equity in these populations. With respect to recommendation, I highlighted to you several gaps. need for tailored integrated care, identifying at-risk populations, limited data on social determinants of health, diversity of studies that exist, as well as patient-recorded outcome measures that are important to assess. So our recommendations for you will be to refine integrated care processes in order to ensure that there is appropriate modification and tailoring to vulnerable populations. This can be achieved through clinical trials, test implementation and feasibility of various alcohol treatment algorithms, obtain robust telehealth equity data, including access, engagement, and satisfaction to reduce disparities in care. With respect to comprehensive approaches for risk management, screen for mental health and cognitive function, utilize biomarkers of alcohol use, assess risk and mitigating factors to negative emotionality and cognitive dysfunction over time through longitudinal studies, collect, share, and analyze social determinants of data, social determinants of health data more and more broadly, including language and health literacy, and the intersectionality of these factors with biologic and interpersonal factors. Have inclusive engagement through fostering research participation of diverse populations, especially minority groups, marginalized or socioeconomically disadvantaged populations, to allow for better allocation of resources, and prioritize patient-reported outcomes and experience data to inform research and care appropriately in these populations. I wanted to acknowledge my collaborators, our mentees, research staff, patients, and of course, our funding from NIAAA. Thank you very much for your attention.
Thanks so much, Mandana. That was terrific. So last but not least, in this session, I'd like to introduce Dr. Justine Welsh, who is you want to make sure you're all set up there. Are you pulled up? Okay. Oh, okay.
I don't want to touch
Our hero today. She's a child, adolescent, and adult addiction psychiatrist and an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. She's also the founding director of the Emory Healthcare Addiction Services and serves as the medical director of the Addiction Alliance of Georgia, which is a collaboration between Emory University and the Hazelden Betty Ford Foundation. And she's going to be continuing our focus on minoritized populations and women and, vulnerable groups. So great.
Thank you. All right. Good morning, everybody. Did everyone have enough coffee? We're going to have a break soon. Leave it to the addiction specialist to ask about your caffeination. All right. So this morning, my topic is going to cover integration of care delivery. And again, I'm going to be focusing primarily on women and also taking a look at minoritized patient populations. Let's jump right in. I do want to call out in the upper left-hand corner an R01 that we have funded by NIAAA. So thank you, thank you. I'll be referencing it throughout the talk today. So what are my goals? Well, the first goal is to highlight an unmet need to address alcohol use in reproductive age women. Now, we heard this a number of times yesterday that rates of alcohol use are increasing, as well as the medical complications, particularly in our younger women. We'll also be covering the impact of race and ethnicity on care access, as well as the impact of alcohol use on sexual reproductive health. So a little bit of a different spin for this group. I'm also going to be encouraging the implementation research for substance use in this population and using the iStar study as an example of this. So moving on to background here. As we heard yesterday multiple times, the prevalence of alcohol use in women is increasing. And now that gender gap, so that percent prevalence difference that's historically been there between males and females, is starting to narrow. And this is particularly true for our younger patient populations. Women also exhibit a faster progression between the onset of regular use to treatment requirement for severe alcohol use disorder. And this is a phenomenon called telescoping. We've known about this for many years. Gender minorities, including transgender and genderqueer women, are also more likely to misuse alcohol than their cisgender counterparts, so twice as likely here. And I believe we're all familiar that there are barriers in access to care and disparities, especially for racial and ethnic minorities, those with lower socioeconomic status, who are uninsured, underinsured, and rural residing. And this holds true for women. So as many of you know, alcohol use is associated with significant medical complications. But in addition to that, sexual and reproductive health outcomes and consequences. So we know that the rates of alcohol-associated liver cirrhosis are increasing at a faster rate in women. We heard that yesterday. But there's also gender disparities in access to treatment for alcohol use disorder in those individuals who have been diagnosed with alcohol-related cirrhosis. We also see a number of sexual and reproductive health consequences. So alcohol use, go figure, is associated with an increased risk of sex while intoxicated. And that is associated with condom and contraceptive non-use, sexually transmitted infections, non-consensual sex, sexual violence, and unintended pregnancy. So when you're thinking about pregnancy and alcohol use, you also see a greater risk of fetal alcohol spectrum disorders, miscarriage, and prematurity. There is a significant need for a more comprehensive and intersectional perspective of sex and gender and addiction and alcohol use disorder and how that relates to race, ethnicity, sexual orientation, and other social characteristics. So this here is a figure that demonstrates how all of these fit together. So you're looking at system level factors, a criminalization of substance use, punitive laws while pregnant and parenting, some of the structural racism and sexism that women experience. Then social, the interpersonal relationships, the parental responsibilities that women may have that males may not. Then looking at the psychological, the impact of trauma, the trauma exposure that women have experienced. And then the biological and gender. So biological, looking at the pharmacodynamics of drug use, of sex-based hormonal impacts, pregnancy and postpartum physiologic changes, and gender, and how all of these intersect is quite complicated. So how do we address the needs of some of these women at highest risk? So I'm going to be providing the iStar study, which is funded by NIAAA, as an example of this. So study setting here, family planning clinics, which are a vital point of access to care, especially for women during young adulthood. And again, we heard about that demographic group of our young adults having increasing rates of both alcohol misuse and alcohol-related medical complications. And now these clinics function as a source of safety for marginalized or disadvantaged groups in the US. So individuals who may lack insurance, be underinsured, or have fluctuating levels of insurance, who might not be engaged in longitudinal care in other types of treatment settings. At this point in time, little is known about substance use services, including SBIRT, in these types of settings. So what do you think our study's about? Do you think it's about SBIRT? So what is the iStar study? So the iStar study stands for Implementing Services and Treatment for Alcohol and Other Substance Use in Reproductive Health Clinics. And it focuses on the implementation, the sustainment, and the scale-up of SBIRT in Planned Parenthood clinics. And so our key partner here is Planned Parenthood League of Massachusetts, which has 4 different clinic sites across the state in both urban and rural locations. And we use a variety of implementation frameworks, including implementation and sustainment facilitation, ISF, CFR, and then for our outcomes collections, REAIM, for those of you who are familiar with some of the implementation science frameworks. And you can see there's a variety of logos here at the bottom. I'm representing Emory. My MPI, Dr. Kelly Hall, represents Columbia. And then, of course, our key partner being Planned Parenthood League of Massachusetts. So our aim one, which I'll be presenting some of our preliminary results for today, is to investigate the organizational practices and perspectives on alcohol and substance-related services. So what are those barriers and facilitators that are most salient to the widespread uptake of SBIRT in these specific settings? So we're looking to the staff to better understand those barriers and facilitators, but we were also looking to patients to help describe and understand the ways that SBIRT might need to be adapted to fit their needs in this specific treatment setting. And now our aim two, which we are about to start enrollment for, is a dual randomized type 1 hybrid effectiveness implementation trial. And that's testing SBIRT both in person and virtually versus usual care. And we'll be enrolling over 600 patients across the 4 different clinic sites. So enrollment numbers pretty high, but you can see how busy these clinics really are. And what we'll be doing is tracking some implementation strategies. So what we do is going to help the clinics implement the intervention. So ISF will be monitoring some of the implementation outcomes. So how consistently is SBIRT being employed? What is the fidelity to that model? And then we'll be testing the intervention effects on the primary effectiveness outcomes. So the primary outcomes looking at reduction of alcohol and other substance use from baseline out through 3 months. And the secondary is looking at measures of well-being as well as sexual and reproductive health. So have we been able to impact the rates of STIs and unintended pregnancy in this patient population? We'll then be looking at differences across the clinic, so the rural versus the urban, and then we'll also be seeing, are there differences across race, ethnicity, as well as sexual identity and other social characteristics. So here you can see it all coming together. In that box at the bottom, you have women's health and health equity and how that intersects with behavioral, sexual, reproductive health outcomes. You have Planned Parenthood League of Massachusetts, which is a large regional affiliate that is within a larger national sexual reproductive health organization. So the Planned Parenthood umbrella, which gives us an immense ability to scale these types of services at a national level. We're using theory-driven approaches within different implementation science frameworks, and then we're using partnered implementation facilitation, ISF, to really support the clinics in being able to implement SBIRT. So this slide here is not meant to give you a migraine. I was not, expecting y'all to squint here, but really it's just to demonstrate that this is a stakeholder-driven model. And so we are using CFIR guided measures and constructs to develop the questions within our surveys and our interviews. And we're looking at the intervention characteristics of SBIRT, how well that fits, the inner setting, the outer setting, and then we're also looking at the characteristics of individuals. So what are the specific needs in this patient population, and then adapting as a response to this. As I already mentioned, we're using REAIM to collect our outcomes. So we're looking at not only just the effectiveness outcomes, the reduction of alcohol and substance use, but we're also looking at the implementation outcomes. What's the consistency in which SBIRT is being employed? What is the fidelity to that model? And so you can see some of those listed here. So I don't have a lot of data for this talk, but I will discuss some of our preliminary A1 findings. And so from our survey, we found that about 1 in 3 clinical care staff already reported the use of a standardized screening tool for substance use in the last 3 months. It's pretty decent. Of providers, 44% already reported screening all of their patients for substance use, which I was optimistic about. I was actually pretty impressed, but 1 in 3 screened nobody. So we have room for improvement. What I really like to see is that 77% were very or somewhat confident in asking questions about quantity and frequency of substance use. But then what I love on this slide is that 96% of providers agreed or strongly agreed that patients at Planned Parenthood who used alcohol or other drugs would benefit from SBIRT, and that in 87% of providers, they felt specifically that SBIRT would be suitable for their patients. And so talk about provider buy-in. And this is something that is crucial in these types of fast-paced treatment settings. We also spoke with staff about the various visit types and the identified roles of how do you actually deliver SBIRT. And so the visit types that they identified that would be ideal for SBIRT included preventative care annual visits, PrEP, gender-affirming care, and long-acting reversible contraceptive visits. Now, this study is taking place in Massachusetts. Abortions are still legal in that state. We do not have abortion listed here because there was a mixed response from providers. Some felt that it would be inappropriate to be employing or using SBIRT in these types of visits where there's kind of a heightened emotional sensitivity of some of the women coming in. But other providers thought that the surgical abortion visits would actually work well because there's already some level of substance use screening in relation to anesthesia. And so that's already occurring. Would we be able to implement the brief intervention and in what context? We also identified specific roles, so healthcare assistants and being able to administer the screening, then the clinicians and nurses for the brief intervention. And then something that we didn't realize is that there's already an existing patient navigation team that's in place to respond to domestic violence. And so being able to repurpose that navigation team and provide them the training to also intervene in cases of referring to treatment. And now I know not a big fan of the referring piece. But what we're hoping to do here is really make this more of a warm handoff and a linkage to care versus handing out a here's your treatment resources, go find them type of deal. And for our patient interviews, overall, patients felt that Planned Parenthood provided an inclusive, warm, welcoming environment, and that they would be comfortable being screened for substance use and having it addressed in these visits. And this also was very evident in patients who were receiving services for sexually transmitted infections. They felt that their providers already had the skills to be having challenging kind of nuanced, complicated conversations, and that actually talking about and addressing substance use would go hand in hand with counseling on high-risk sexual activity and then substance use as well. So they felt very comfortable and supported by their providers in this way. One of the interesting things that we received was feedback from both the patients and the research staff embedded within PPLM, or Planned Parenthood League of Massachusetts, who were doing the interviews with patients who were receiving gender-affirming hormone therapy. And so one of the questions that we were asking was, are you assigned male at birth or female at birth? Because we were using the audit C to stratify risk, and those are very different. And we received multiple questions about what is the science behind this? And is this validated in cisgender individuals, which the audit C is? And so there were questions about, have we taken into account the potential metabolic changes affiliated with gender-affirming hormonal therapy in these individuals? And does the audit C need to be modified in that context? And has it been validated in trans individuals receiving these hormonal therapies? Our answer is no, the science is not there. And so the request was actually to lower the threshold and assign the assigned female at birth category to all participants coming in through this pathway, which we did. And we still need to determine what we're going to do for our randomized control trial as part of AIM-2. So really crucial and important feedback that I think we would have overlooked had we not done these surveys and these interviews before actually employing the intervention. So moving on to my summary and recommendations here. So as I highlighted, there's an urgent and an unmet need for substance use services in reproductive age women. Collaborative partnership with sexual reproductive healthcare organizations is crucial, and we can do this through implementation science. And further research is necessary to implement effective and informed screening of gender minorities. So my 3 take-homes are built off that. We need to explore the use of standardized screening scales in gender minorities, which we just simply have not done to date. We need to develop more stakeholder-driven, patient-centered approaches to SBIRT implementation, especially if we want these SBIRT to be successful in these types of settings. And then we need to use family planning clinics to be able to scale up integrated alcohol use disorder services in order to reach marginalized group of women at a crucial and critical point in the life course. So, thank you.
So I think we'll have all of our speakers come up to the front for questions. Go ahead.
Rebecca Roediger, I'm a hepatologist at Montefiore. Thank you so much for all the great talks. This is a question for Dr. Sengupta. We, as we discussed last night, we recently at Montefiore opened a multidisciplinary ALD clinic. And
Could you speak, oh, I'm sorry. Could you speak a little bit closer to the
Yeah,
microphone?
sorry.
It's hard to.
a little taller than this
You
mic.
can take it, you can take it off of there too, so it's, you don't have to cry.
I was curious if you discharge from your clinic back to regular hepatology when the patients have recovered and perhaps don't need the intensive multidisciplinary care to make room for new referrals? And if so, what criteria do you use for knowing when it's time to discharge?
Okay, that's a good question. We decided never to discharge anybody unless they wanted to leave our clinic. You know, I think we take people with advanced liver disease. So from a hepatology perspective, there's, you know, I can follow them longitudinally. We discussed this a lot with our addiction psychiatrist, and our thought was if they'd been stable for 5 years from an AUD perspective, that maybe they would just follow with me longitudinally, or we would send them to hepatology at that point. I think we'll see what's going on at 5 years and reassess.
I thought it was interesting to compare Mandana and Shreya's model, and they're not mutually exclusive, but one is sort of using the telehealth model. And I wondered, Tiffany is online here, maybe you want to comment, and something we're trying, it's an experiment in Mayo to, again, recognizing the challenge of the scalability of a internal multidisciplinary clinic, given, you know, overbooking, all these challenges. So Tiffany, maybe you want to make a couple of comments on the this model and how we're testing it?
Sure, yes. So thank you, Dr. Shaw. At Mayo Clinic, myself and Dr. Simonetto, along with one of our fellows in GI, Camille Kieser, we've been developing a digital ALD clinic to try to overcome some of these barriers as far as access, as well as the challenges that Dr. Sengupta outlined and experienced in trying to develop an integrated care clinic. And certainly, while itself has some challenges with the digital clinic, we've decided to and opted for approaching this from a research perspective to be able to partner with digital therapeutic companies who have different models of their own operational business models, where we feel like they have the ability to innovate and pivot and scale very quickly, because they, of course, if they're considered the startup companies, they have a lot more funding to be able to do this and do it under design that is user experience based and that they can quickly scale up. So those finding a partner and then coming up with a research-based model to try to develop this implementation in the clinic, that's been an approach that we are starting up and looking to hopefully continue and sustain. We've just started enrolling our first patients in a pragmatic trial design, and that has been very a challenge from the perspective of IRB and getting approvals there. But I think once we overcome those barriers, then there's much more room to scale. So I'm happy to talk more about that, but I appreciate all of the speakers. Sorry, Dr. Lucy, to kind of jump in with the question for the speaker teams. But thank you for a very enlightening mix of presentations. This was exciting to hear. And because of our interest in being able to work through telehealth-based models or digital models and solutions for care and working with vulnerable populations, and I realize, Dr. Walsh, this is probably part of your aims, but what would be important for us to keep in mind in how do we tailor those digital models and digital technologies in a way that is going to be the most effective to these vulnerable populations? Is it going to be incorporating trauma-informed care? Is it going to be incorporating different outreaches? And I love the idea of being able to partner with family planning clinics to be able to do so.
From a digital piece perspective, I think it's really important to assess and evaluate the patient's perception of the care they're receiving. I think that's where we realize that there may be differences, and how to navigate that requires a lot of sort of understanding of the culture of the system within which you live, but also the resources that are available. So that certainly requires quite a bit of thought processes behind them. But I think the first step is really to evaluate and better understand, not just satisfaction or utilization, but also the perceptions of care. And then I think from a linkage to other services.
Yeah, so excellent question. I think it's really about patient engagement. So, well, it's about all of these things. It's about resources in the community, resources that you have yourself, but hearing about, other people's experiences and having to provide 18 different calls to families. Well, that's the world I live in. We are looking to engage our patients in care. And if a call center is providing one single care, maybe without an interpreter, there's going to be an issue if that family can't even understand what the voicemail message was to call back. Who are they calling back and why? So I really think it's about understanding the patient population, being able to engage them, and then have those wraparound services to keep them retained in treatment and care.
Thank you.
I was going to make 3 quick points if I can. The first is we've also started a multidisciplinary clinic, and we've got great help from Jessica. So that's the first thing you need to do. If you want to start one of these clinics, you've got to contact Jessica, and I'm sharing her now with everybody. The second is it won't be quite the same as what she has done. And so one of the challenges, and this was actually raised from the very start of this conference by VJ, is that these clinics largely do not make money. And so how do you convince the people who need to be convinced to do something which doesn't make money? And I would say a key thing is to understand the culture of where you are. So in the University of Wisconsin, we're very keen on something called the Wisconsin idea, which comes from the university, which was the idea that sometimes summarized as let the boundaries of the state be the walls of the university. So if we can convince the people that we are serving the people that we are here to serve, you have a better chance, even if, and then you got to say, well, it's not going to cost much money. I mean, you're still going to be pressed about the money, but you're going to try to get them on your side from a moral point of view. And the third thing I would say is about leadership. And leadership doesn't just really come from the top. And often you're looking for middle leaders, which sometimes might be called champions here. So in our case, the nurse manager of our digestive health center, which is where we're locating our clinic, that's a freestanding center away from the medical campus, but it's where we have our main GI services. She provided both leadership, drive to get through various committees, and promise space and support from nursing and MAs. Now, without that, we couldn't have done this. So finding the right middle leaders, the champions who are going to work for you. So there are my 3 things: Jessica, culture, and find your leaders.
I'd point out one thing too to what Michael said is that I'm always happy to help anybody. It's very fun to see these clinics take off. One case that you can make is transplant, actually. Transplants are extraordinarily lucrative, right? And we know that there are many ALD patients who should be considered for transplant, but who aren't. Whether because they haven't, connected to AUD treatment or because the providers just don't know that, you can actually think about transplant in people who've been less than 6 months, et cetera. So also knowing what your transplant conversion rate is out of your AUD clinic, ours was 3.5%. So 3.5% of the patients who came through our ALD clinic ultimately went on to successfully get transplanted at our institution. And each one of those generates, whatever X amount at each institution is different in net profit. And it also has the moral case of we find people who maybe otherwise would not have been considered for transplant, get them prepped for transplant, go forward, and get them the care that they need. So there are financial cases to be made for it that connect to a transplant center. I would also say that the collaborative care model, and I think others who've done this, like Stacy could probably speak to this a little bit better, there is an ROI on that. So at University of Michigan, we were looking at our behavioral health collaborative care group who will come into our clinic, into our ALD clinic and help manage that case management, panel management, et cetera, approach. They get 150%, so 50% above the output ROI back. So it actually, like, that aspect of it does make money. So you can kind of do these things, T-code billing for all of your, all of the, 30 minutes that your nurse spent on talking to them. There are ways that I think we are missing revenue that we don't know about, that in collaboration with our primary care colleagues who've been doing collaborative care for umpteen bajillion years, know about this stuff and know how to make this at the very least revenue neutral. I don't know about cost savings, but moving forward, doing that. We also published a cost effectiveness analysis a couple of years ago that showed that getting patients medication therapy or behavioral therapy who have cirrhosis was cost saving. Okay, so if somebody, I think Dr. Bray is going to talk about cost effectiveness. I don't know where you are, Dr. Bray, but hello. So he'll probably talk with you about like the difficulty of getting cost savings and how cost effectiveness is not cost savings. But what we found was that it actually was for this population to get them access to AUD care. So there are arguments that you can make, and we can talk more about that. Right, go ahead.
Hi, I'm Erin Phillips. My question's for Dr. Sterling and follows very well.
Can you
with
speak
Dr.
into the
Oh,
microphone a little? Sorry.
yeah, sorry. Hi, is that better? Yeah, sure. My question's for Dr. Sterling. It follows very well off of Dr. Lucy's comment about culture. But I want to thank you for sharing your findings about the differences in what was causing some of the variation in implementation, the organizational structures you were seeing. I'm curious if you also looked at differences in culture across sites, like there are cultures that are more or less supportive of innovation, more or less supportive of teamwork or higher versus hierarchy, and if that's something you looked at as well, or if you have intuitions about whether or not that might be impacting the implementation.
Yeah, actually, the survey that we did assesses a lot of those factors. So is your chief supportive of innovation? And it's captured in a lot of that infrastructure, implementation and sustainment infrastructure. Those questions really relate to that, that sort of supportive culture, as well as the recipient domain. So yeah, we had, our survey really captured the differences. And, we thought for a bit, maybe the differences are that in very busy clinics with higher numbers of patients in panel, a higher panel size, that brief intervention rates would be lower because people would be really busy, but that really wasn't the case. Actually, higher panel size was related to better performance. And so we thought, well, maybe that's a reflection of medical centers that are, I don't know, better staffed or more robust in some way. So we're still digging into this and looking at more granular level of the specific factors that the providers seem to feel were associated with implementation. But yeah, absolutely.
Thank you.
Hi, two quick questions for Dr. Sterling. Did you notice, you may have covered this, so sorry if I missed it. Did you notice a difference between the provider type MA versus physician or, other who did the audit C in terms of downstream effects of that, SBIRT, creation, diagnosis of, ALD?
Well, we didn't use the audit C, but we used the NIAAA screening question. So in the earlier pragmatic trial that I mentioned, the ADVISE trial that was led by Jennifer Mertens, we tested a model where physicians were trained to do every aspect of SBIRT. So they did the screening, they were trained to do the brief intervention and the referral to treatment. And in the other model, there was actually 3 arms. One was usual care. And then the non-physician provider model, the medical assistants did the screening, and non-physician providers, so psychologists who were embedded in the clinics, did the brief interventions. And what we found is that in the physician arm, screening rates were really low. And in the non-physician provider arm, medical assistants had pretty high rates of screening. However, the brief interventions, when you went down here, in the physician arm, a pretty high percentage of brief interventions actually got performed, whereas there were problems with the handoff, and many of the people screening positive in the non-physician arm actually never got their brief intervention. So that's why the system decided to adopt sort of a hybrid model where MAs do the screening. It's part of, we lucked out getting it right up there with smoking and everything else went during the rooming process. And then physicians are trained to do the brief intervention and referral to treatment.
It's so interesting because you're trying to normalize it, but, patients don't necessarily know that either, right? And so it could be a little jarring for an MA to, ask about, what's your pharmacy and then your drinking habits, right? But
Well, they're asking about smoking.
Yeah.
They're
no.
taking your weight. They're asking whether you have, how much you exercise per week. And so they ask, I don't know if it's jarring anymore. It's been in place for 10 years now. And
I
so-
think you're convincing me that it's
Yeah,
not. Yeah.
something like 80% of our adult population has been screened at this point. So by now it's just like, oh yeah,
Yeah,
they're
yeah.
gonna ask me about that.
That's great.
But that was part of the normalization process, right? And that's why we were like, we're not we're not singling you out, Justine. We're asking everybody.
A quick question for Dr. Sengupta. How do you navigate the transfer of care for post-transplant patients with ALD? So are you taking over their care, including the post-transplant side? What's that relationship between their previous, provider? Is it just a one-off or a brief time and they go back to their hepatologist? Can you speak to that?
Yeah, I'm greedy. I never give anybody up. Once they come to the clinic, I make it clear. Some people have really, really established relationships with their hepatologist. I leave it up to them. Do you want to continue to follow with both of us? We see you every 6 months. We work with people, but in general, if they transfer their care to me, I'm taking them to transplant, through transplant, post-transplant, we're taking over their care. As our referral volumes and volumes increase, I'm curious how we'll adjust. But the idea has been that once they kind of belong to this multi-D clinic or this medical home, it's better to sort of capture them and keep them there.
Great. One last question. Go ahead.
Thank you. Glad I made it into under the radar. Scott Biggins at University of Pittsburgh. My question is about branding and having a flag to fly under. You have all these stakeholders. You have your patients. You have the hospital system. You have your internal, external marketing. And I'm just thinking, when coming up with a name for a new clinic, is how did you do that? And over time, from yours, Dr. Mellinger, to Dr. Sengupta, all these, has it evolved? Like with NASH to MASH, is it good to have alcohol in there? Is it all encompassing to have addiction? Are you looking at it's branding, and if you were developing a clinic today, what would be the best nomenclature to use?
Yeah, that's a great question. I mentioned some of the issues with part 2. So our original program name was the Multidisciplinary Alcohol Program, because at that point I wasn't clear, I wasn't sure if we were going to exclude people with alcohol-associated pancreatitis. It was going to be sort of an alcohol-related GI plus liver. And the legal team made it clear that there were significant legal ramifications of calling it an alcohol program. And so we actually ended up, and then we realized it really wasn't truly reflective of our inclusion criteria. And so we changed it to ALD program. And there's a little bit of like, it seems like a little bit of a gray area where it's like, you don't say alcohol, but you know it's alcohol. And then I think making it ALD and calling it MAP clinic is also great for patients because many of them are very sick. They require transportation to appointments. They can just tell their family members, hey, I'm going to MAP clinic. Nobody asks. You know, not making alcohol prominent also helps with patient confidentiality. So we realized that and actually changed our name. Thankfully, we didn't have to change the acronym.
What about the D? Disease, disorder, health? I'm just thinking,
We call it ALD, so we just use the acronym and we try to leave like disease, chronic, cirrhosis, anything out of it. So it's just multidisciplinary ALD and then program. So if you delve into ALD, you can get into the specifics of it, but we've left it acronym based.
I would not name mine the main clinic if I did it today. It's just way too long. It's like Michigan Alcohol Improvement Network, multidisciplinary LD. It's like, oh my God, why did I do that? You know? Where was ChatGPT when I needed it?
Can I just make one quick
Yeah.
comment about the 42 CFR Part 2, which just rolls off my tongue because I live in that world? There are some of those restrictions being repealed and scaled back so that we're going to be much more closer in alignment with HIPAA level protections. We will have some additional reporting requirements, but some of the nomenclature issues and the sequestration of records may not be as applicable within healthcare settings. So I encourage you all to check with your lawyers because that is real-time information.
Yeah, and it'd be great if they did that because that's such a stigmatizing thing. I mean, I know it's done because of stigma. I understand that, but it also sets up this idea at the national level that, oh, we have to completely sequester these records about substance use so nobody can see them, as if it's not medically relevant for us to know that somebody has a substance use disorder. You know, it's really challenging and sends completely the wrong message, I think.
It really inhibits integration.
Oh,
Even
yeah.
in our integrated system, the addiction medicine programs are considered freestanding for the purpose of 42 CFR, freestanding programs. And so for many years, there was not the flow of information between primary care and addiction medicine, even in a program like ours.
Right,
system
it's
like ours.
crazy.
It's crazy.
Great, well, we'll take a short break and convene at 10. Does that work?
I'll just premonition that we're going to sort of integrate the rest of the sessions, and Sumit's prepared, thanks to Sumit, a lot of, well, I don't know, some content around all of the summaries of things to facilitate discussion. So we'll have the two talks, and then we'll just move straight into just a group panel discussion. So it'll be a great chance to really all listen and learn from each other. Mhm.
Hello, everyone. Let's resume our last leg. And I think it's a very important leg of the meeting. It's really to pull everything together. I hope we have a really strong discussion afterward. So we have, this session is about outcome and outcome assessment. We have two outstanding speakers. The first one is Dr. Pillai. Dr. Pillai is a professor of medicine at the University of Chicago Medicine. She's a board-certified gastroenterologist and transplant hepatologist, and specializes in the management of a chronic liver disease and a hepatobiliary malignancy. Dr. Pillai is the medical director of University of Chicago's multidisciplinary liver tumor program, co-director of adult living donor liver transplant program, and the program director for the ACG ME accredited transplant hepatology fellowship. Thank you.
Yeah, so you're probably wondering why I'm talking about alcohol, since none of that had anything to do with what I do normally, but we did develop our alcohol associated hepatitis protocol for transplant, and myself and John Fung led it in our program. But really, I think the task was, talking to Dr. Wang and Dr. Shah, is kind of looking at, from everything that was discussed in the last day and a half, trying to figure out what success is. And it's somewhat aspirational, right? And Dr. Mellinger said, if we can get Beyonce, but her husband JC actually owns several liquor products. So yeah, that's why they're billionaires. So that's not gonna happen. But the idea of like de-glamorizing, right? I think those kind of things. But so I'm gonna talk about it from different aspects, maybe a global national policy perspective, and then more individual and center driven. So these are my objectives. So defining global and national policies. I think if you really, really want to curb alcohol use, that's very important. And it's been shown that this curbs, alcohol-related detrimental health effects. And then what are the pathways, many of which have been shown here, and then identify metrics for success, whatever they may be. And it doesn't have to be perfect. We really have to just implement some of these policies that are well-defined. So alcohol use, as we know, is rising globally. So in 2019, before the pandemic, 25% of cirrhosis-related deaths were due to alcohol. So now that's probably more, right? And if you look at the very dark areas, that's Russia, and just a geography lesson, right? And then Kazakhstan, Mongolia, Greenland. So lots of alcohol in areas, and there's actually policies to learn from some of these countries. And as we know, it doesn't just affect the liver. This is a large Danish study of over 20,000 patients. They looked at people that were diagnosed with alcohol-related liver disease and 15 years out. And in the first 5 years, it was all liver-related mortality. But after that 5 years, it's all the other things: cardiovascular, other cancers, and non-extrahepatic manifestations. So this really leads to increased healthcare costs and a burden economically. And so the WHO, this was their goal, was a 10% reduction in harmful use of alcohol by 2025. They changed it to 20% by 2030, okay? And so there's strategies that I'm not going to go through. And harmful, as we've discussed, is detrimental health and social consequences to the drinker, people around the drinker, and society at large, and then patterns of drinking that lead to adverse health outcomes. And I liked that in the bottom, they said harmful as related to public effects of alcohol, right? But not without prejudice to religious beliefs and cultural norms. So I think it's important, we all talked about culturally sensitive rehab programs and interventions. So this is a study looking at alcohol preparedness index, and it's a global study of 169 countries. And they essentially looked at how many countries had public health policies on alcohol. And the more that you had, the stronger correlation was to, decrease AUD prevalence and mortality, cardiovascular mortality, all these good things. So just want to use Russia as a case study. So we talked about Scotland, which is the highest alcohol use in UK, and they increased their MUP to like 0.5 pounds, and they had a 3% reduction in mortality. So Russia's been doing this for a long time. If you look at Russia earlier, several decades ago, they had very high mortality, especially among their young persons. And these are largely men, largely also smoke. And you can see that all-cause mortality and alcohol related mortality really correlated. And so what they did is that in 2006, they actually had strict regulations to alcohol use, and they did it in 2 different phases. So the first phase was kind of controlling consumption, and the second phase was really at reducing overall health outcomes and mortalities. And you can see this again before the pandemic, they really still have a problem, but yeah, there was significant decrease here in men and women. And so once it was like the highest, their life expectancy previously was 57 years for men, which is crazy. And this was in the early 90s, not like, 1800s. And so then, through 20 years of hard work and very strict regulations, they increased life expectancy to 68, which is still below many, big countries. But How did they do it? Like very, very strict things that maybe that we couldn't do, but they incorporated audit. They had an all Russia sobriety day. There was presidential grant funds that were given to promote healthy initiatives and education plans, and they have a very centralized system that controls all alcohol production in Russia, right? So that really worked. And they increased taxes by 50%. So, and banned sales at certain, so very, very strict policy, right? So just to say, creating some kind of national public health policies are key. Okay, so let's look, just switching gears. I know we're going to talk about cost, but this was a recent study. So we talk about multi-D care and how do we make this cost effective? In reality, when you're talking to alcohol lobbyists that say like liquor sales are helpful to economy, it's actually not, right? So if you look at the GDP of most countries that have this, 1 to 3% is going to be for downstream detrimental health effects related to alcohol. So the first graph shows annual, this is looking at 2020 to 2040, what would happen if nothing changed, right? So annually, there's 118% increase in healthcare costs, both direct and indirect. And if you look at cumulatively, it's $880 billion, just a lot of money. And so who are you losing? You're losing younger people. Oops, sorry. So you're losing younger people in the, at the prime of their work period, right? So you're losing a workforce, and it's largely also affecting women now, as well as increasing healthcare costs, mortality, disability. So the same group looked at this in the sense of intervention. So we talked about smoking, Dr. Lucy had brought up. So when the Surgeon General showed, smoking in 1964 and its detrimental relation to health, since then, over 40 years, there's a 75% decrease in cigarette use. So a strong intervention, right? And so here they're looking at what would we do if things stayed status quo as far as just death rates. So it would go from 8.2 to 15.2 per 100,000 per year in 2040. Even if you did a moderate intervention, which is on the top left graph, it actually still goes up. So really you need a strong intervention. And I think a lot of this is national policy level. I know we don't like to talk about policy, but that would actually that would lead to decreased deaths, right? So when we talk about success, I do think we have to look at from a global standpoint. And then I wanted to kind of take it home a little bit more. So as I was thinking when I was defining success, what's going wrong here, right? So that's New Mexico. I knew New Mexico had high nationwide deaths, but if you look at the yellow bar, which is average nationally to New Mexico, they have the highest rate, and that's despite other states that are poorer and have more drinkers. They still have the highest death rates, and 1/3 of all deaths is related to alcohol liver disease. And the majority of AUD patients are not referred to treatment. This is New Mexico where ECHO started, right? So, and there is no transplant center. Their one transplant center was shut down in 2000 and never restarted. And then when you look at health disparities, I highlight McKinley County. There are several where there's a large Native American population. And so Native American population somewhat isolated and higher, I forgot the exact, it was like 4 times higher than even the Anglo and Hispanic population, but even those populations were higher than the rest of the country, right? So thinking about what are missed opportunities, areas of intervention when we're thinking about success. So it's a cultural thing. I read all these newspaper articles, got really into it because I couldn't believe it, the data actually. And it's like, making alcohol acceptable all day, every day. It's glamorized, it's fun, it's your identity. You go to sporting events, it's family gatherings. You don't want to be ostracized. That was discussed previously. But it's also lack of early screening, right? So there's no, and Marina showed this nicely, depending on where you are, you can't get to places. So there was lack of screening. And then there was shame over diagnosis. Why are people not going into centers? There's still a huge stigma, and there's limited resources. There's not a transplant center, so you really have to fly out somewhere. And then how do you, and there was really no referrals out. So how are you kind of going out to the rural areas? And as far as the Native American population, there was really a shared history of trauma, right? So land was taken away, families were ripped apart, and alcohol became the norm. And so then there's these huge inequities and disparities, and you have to go out there to bridge that gap. And how do you do that? So there's a lack of access and decreasing those barriers to access. And some of these slides have already been shown. So again, just emphasizing somehow integrating treatment early is key, right? So this was a study, pharmacotherapy for AUD, which showed that if you did it, it was great. It decreased decompensation. And similarly, even in transplant center, this was in Italy, they had an addiction unit with the transplant center. This was in Rome, and they showed that if you had that post-transplant, decrease return to drinking. So there's ways to intervene before bad things happen. And then Samit showed this as well. So beyond global, how do you look at it on a local, regional, right? Population screening, we talked about a lot. So we have all these tools. It's actually implementing them, right? And then getting out to the community rather than waiting for them to come to you, and then individualizing treatment. And again, integrated pathways, which again, we've talked about a lot. So going away from just unaffiliated and formal to what you guys have done, which are really co-located and collaborative. So how do we put this together? There was a lot of great discussion the last day and a half, right? We need to identify patients when they're asymptomatic. We need to integrate these clinics. We need to have culturally sensitive programs. We have to promote effective prevention. So lots of stuff. So and a lot of this has to do with addressing societal individual factors leading to harmful use. From a society standpoint, it's all these things we already talked about: economic development, culture and social norms, media, marketing, glamorizing alcohol, availability of alcohol. So for instance, Massachusetts banned happy hours, right? So this was done some time ago. And do you know why that happened? Is that there was a young woman who was given drink tickets. We talked about drink tickets for naming the most tunes. Okay. So she got all this free alcohol. She got into a car and she dragged her friend underneath the car who, unfortunately died. So then since then, Massachusetts does not have happy hour. So, we're kind of doing things disparately, right? There's no big global there's no national structured standardized way, but there are things that can help. And then individual factors, age, historically men, but now it's men and women, and younger people, and then family history. I should have put patterns of drinking in here. That's what, in Russia, they showed why was it so disparate compared to other countries? It's because they binge drank. So the highest level of drinkers would drink 5 half liters a day, but then would have 3 days of abstinence. So it was like this pattern of binge drinking, right? And then socioeconomic status, we do know that alcohol affects all socioeconomic status, but the most vulnerable and lower socioeconomic status patients have decreased access to healthcare and so have more downstream effects. So Dr. Wang had asked me to kind of put a toolkit together, and I try to figure out if this is what I heard properly from the last day and a half. So we said that it should start early. So from the PCP office, maybe they can be the quarterback, right? So what would you do universal screening, and then do you have the resources to do feedback and brief intervention as well as labs and a fiber scan? I think that's actually very doable to get a fiber scan in your clinic. And then based on patterns, referral to addiction. But what about people that cannot get to the PCP? I think you do have to have public awareness and screening booths at youth centers and shelters and cultural organizations. So how do you actually implement that? And then once they're a little sicker, they usually come to GI or hepatology. So we should have a standardized approach on how we would do that. So again, I like the idea of universal biomarkers, biosensors, the work that Tiffany is doing, and then looking at who would be at the highest level of decompensation, right? Using ELF, PNPLA3, and again, imaging and mental health resources. Peer support groups are really important and help. My cancer patients are often sent to patient advocacy and peer support groups. And then when they're really sick, this is probably where integrated clinics are most likely going to be, from a resource standpoint, put into place, right? And again, at this point, you want to refer to transplant. You need nutrition support. You need ways to figure out how are you going to monitor decompensation. And again, all the mental health stuff, right? So what if they get transplanted? Wonderful. But what if they drink? Because they often, not infrequently, do slips and relapses. And again, I think it was beautifully said, you want to go back to integrated clinics. I know Brian has done this work, right, to show that there's a therapeutic alliance and not the stigma of drinking as an issue. So that would be kind of my toolkit in my head. But I think also you need to expand this further out, right? So how do you get to rural, underserved? And so maybe webinars, we do that, telehealth tumor boards actually, and sensitive targeted intervention at community centers, places of worship, schools. We talked about a lot of this, and EMR prompts and self-reporting tools. Easier and bigger centers like Kaiser, all the things that you guys have shown are large community health systems, harder for single specialty practices. So this is what, I just reused my multi-D team for liver cancer, which, along with transplant has been established over and over. And we've seen great data now from, internationally and within here from Dr. Mellinger and then Penn and then Dr. Sengupta's talk. So the question that I have is, who's your quarterback? So for liver cancer, it is the hepatologist because we know liver disease and the cancer. So should it be the hepatologist? But then we talk about not having addiction psych resources. Could it be the PCP, but do you have the resources to maintain that? Or is it this addiction psych person? Or is it somewhat, more integrated, which makes it actually hard because I think someone has to take the reins. And I would argue if addiction psych is an issue, just finding we good? Okay. We're not evacuating? Okay. Sorry. So for us, I would say that for hepatologists, being maybe certified in addiction psych would be a good thing, right? People do it for obesity medicine when you do mast cell clinics. So that would curtail that shortage. And then making sure that you have culturally sensitive programs and peer support groups. And then the throughput of like, what is your entry criteria, right? So we talked a lot about it, how Mo does it versus how, others do it. But it seems like stratifying to liver disease probably is the most reasonable. And what do you need beforehand? All I ever ask for is a CD of the imaging. I don't really need much else. I just need to actually see if you have cancer and I can put most of it together, right? So figuring out what your screening and intake is and where your referrals are coming from. So for us, we give a actual script to the referral to our cancer center, to our centralized, that they just have to read it, so that patients don't freak out about being referred to, as we talked about with names, liver tumor clinic, because all tumors are not cancer. And then how do you enact a plan, right? So we have virtual tumor boards. So as you guys already have, you have multi-D boards to review highest risks. And how do you surveil these patients? How often are you doing it? 1 month, 3 months, 6 months? And who's your champion? So Dr. Lucy mentioned this. So we have a nurse navigator, and it's been shown in multi-D cancer clinic, a nurse navigator is utmost importance so people don't follow through transitions of care in cancer. So having a model with something like that, I think that would really help. And how do you measure specific outcomes? What are they? It should not be, from what I think we all agree, a zero tolerance policy, right? It's not never return to drinking. It's harmful use and harmful outcomes. And then co-location, I think, is really important. And if you bundle things together, you actually decrease facility fees, right? So if you're in the same building, and you can be hybrid, you can be virtual, but it is resource heavy. So as Dr. Lucy mentioned again, it may not necessarily help that specific visit, but in the larger health system, it actually does help, right? So 3.5% of your transplant or patients come to transplant, that actually negates some of the costs. For us, 20 to 30% of our patients from our tumor program go to transplant, right? So that's how they saw the utility of why we needed a clinic. So I think showing, you gave a beautiful talk, Shreya, on how to show the worth of this clinic. And so this is a timeline that Dr. Wang wanted me to put together, which has a lot of space in between. So, so if so if we follow and screen all adults, and if our 50% reduction by 2035, 45 is our goal, what do we fill in the middle, right? So yes, maybe we can do EMR prompts and self-reporting tools, but there has to be certain things that are implemented. So I think you do have to have some kind of kit to standardize care, figure out high-risk individuals based on extent of liver disease. And you do have to link medical and mental health resources in a multi-D format. We talked about this. Easier in large health systems, and you need buy-in because it is resource heavy, but ultimately it helps economically decrease costs. And then low barriers to access, right? So in New Mexico, that was the issue. You can't get to places or you're not going to them. So how do you do that? And to dismantle stigma. And then finally, innovative platforms. I think the hardest hit are for single provider systems, right? The PCPs and addiction psych that stand alone in these rural areas. And I think you really have to rethink about how we reimburse patients and models. And if we're really being honest. It's my time, I know. So, okay, so defining success, my last two slides, I don't think you need to be perfect, right? You just have to start implementing it. So there's definitely global things that you can think about, and then national things, a lot of which we already talked about, talking about decreased consumption, mortality, early screening, early access to intervention, and then individual factors. So I think if you kind of put it into buckets, you could do a lot, and it's all established. We talked about it, and I've learned a great deal. So now it's like implementing it to make it actually work. And so this is my takeaway. So implementation of multiple public health policies on a global and national level does decrease harmful use. So I think it goes beyond just what we do. And so advocacy, and then early screening and individualized treatment key, right? So that cartoon, like if you tear apart the life raft, it really doesn't help everybody. So you have to individualize key treatment, and then integrating early multi-D and psychosocial management. And then community engagement, I think, is really equally important, getting out there to the community and bridging this gap. And I won't belabor the key markers of success, but these are kind of the 4 or 5 things that I think are the most important when you're defining success. And then again, the idea that if there are no strong interventions, really, we're just kind of on the precipice of this awful thing happening. We're just kind of go off the cliff, right, in the next 2 decades. And I think just in cancer and in transplant, we know that we can't do anything in silos, and just teamwork is really the most important key to success. Thank you.
Starring. Looking forward. Our next speaker, Dr. Jeremy Bray, is the Jefferson Pilot Professor of Economics at the UNC Greensboro and the President of International Network on Brief Intervention for Alcohol and Other Drugs. Dr. Bray has nearly 30 years of experience in conducting economic evaluation, alcohol screening, and brief interventions program. Thank you.
Thank you. I'll get out of the way, switch sides. Thanks, everybody, and thanks Joe and VJ for inviting me. I'm often the only economist in the room, so I'm somewhat comfortable being in this position. But usually at this time in the program, all but my friends have left. So I will. If I had this to do over again, I would have asked Joe to let me wait and do this presentation, like do my slides 5 minutes before, because I've learned so much and have so many more ideas. We'll see how this moves through. And then of course the title they gave me was interesting. Benchmarks measures of cost effectiveness for prevention model and or initiative, short-term and long-term, and assessment. So I tried to touch on a lot of those things, and we've talked a lot throughout the word cost effectiveness has come up, return on investment, revenue generation. I'm not going to touch on all of those because I didn't know where those terms were going to be used throughout the meeting, but I am going to talk about cost effectiveness because that was in the title they gave me. And really focus on what evidence base do we need to establish for, say, an agency like the U.S. Preventative Services Task Force.
Wow.
Endorse what it is we want to do, right? And they do look at cost effectiveness. Now, PCORI and by the Affordable Care Act, we're prohibited from using quality-based cost effectiveness to set. Yes, we cannot use qualities in the United States to establish healthcare policy. That is And it's not quite as bad as no policy, but we can though talk about other things very related to cost effectiveness. In the USPSTF, which is not a formal government agency, can look at cost effectiveness. So let me get into this. And I don't know how much I need to motivate this, but I'm going to go through this, right? So we all know that money alone is not going to solve a problem. But you almost always need some money to implement to implement a solution, right? And so what economic evaluation does is trying to articulate those trade-offs. What are you spending and what are you getting? Now, there are lots of ways that we can do that. And in healthcare, the two big ones are cost-benefit analysis, often called benefit-cost analysis. It doesn't really matter which order you want to put those. And cost-effectiveness analysis. Cost-effectiveness analysis is what I'm primarily going to talk about because that's more dominant in evaluation of healthcare programs. But this is a place where if I had this to do over again, I'd spend a lot more time on cost benefit. Talk about return on investment, budget impact analyses, and that gets into revenue generation and the business model of the healthcare system. Because we talked about that, right? We know we've got to have revenue generation in these centers where we're trying to implement this. And as much as we might love to eliminate the need for liver transplants, if you do that, your transplant unit is going to shut down, right? So we've got to think about those trade-offs. I'm going to focus on cost effectiveness analysis and really focusing on what we need for the incremental cost effectiveness ratio. And what that tells us is, are we getting what we want out of our money? This is not a financial return, right? Return on investment is, am I making money on my investment? If I spend money on this program, will I get more money back than I spent? That's return on investment, that's cost benefit. Cost effectiveness is, am I happy with what I spent my money on? Right? That's, I'm willing to consume this money. I'm going to go to the store and buy something. I don't expect that something to return a financial return to me. I'm going to consume it, right? That's cost effectiveness. I put this up every time I talk about cost effectiveness, CEA versus CUA. Cost effectiveness is pretty much what everybody talks about. And then we go to QALYs, quality adjusted life years. Technically, that's a cost utility analysis. And I point that out because you don't have to use QALYs. We can look at cost per averted transplant, not cost per quality adjusted life year. Both of those are cost effectiveness analyses. We just use different outcomes. Now I use this picture. This is my favorite figure from the textbook by Drummond. It's a very British textbook. But I love the figure. And so I use it in my introduction to cost effectiveness class. And what I like about it is it really gives us this input-output model of a healthcare intervention. We're going to devote resources to implementing this intervention, and that ties into implementation science and CFR and REAIM and all those things we've been talking about, right? And while Drummond has labeled it as cost, all those inputs, notice there are no dollar signs, or in their case, pound sterling signs on any of these resources. Right? Costs are not about money, costs are about resources. What have you devoted to implement the intervention? Being able to monetize them really helps because then we can put everything together on one big lump sum, here's what it costs. But the problem with putting it all together goes back to some of the things we talked about with, well, will PCPs do this? Can you get a primary care doc to do this when they say, I don't have time with it? And you say, well, it's only going to cost your clinic $5 to do it. Yeah, but that doesn't convey the amount of time that the nurse practitioner or the receptionist or the physician has to spend on this. And how does that impact their workflow? So I always want you to think about costs in terms of resources. And then if we can put it together into a single metric, that's great. But we've always got to communicate what are those resources. And then we get what Drummond calls consequences, right? And Some of that we've touched on when we talk about healthcare savings, right? Those are resources saved. It's important to note that even though Drummond calls these resources saved, those might also be more resources committed. If you prevent transplant and get somebody to live for 60 more years, but live in a state of health where they need high level of care, you're going to spend a lot of money, right? And economists are the dismal science, and we're in dismal science for a reason, right? Years ago, Kip Viscusi did a study on smoking and found you're better off to let people smoke because they die early. Right? That's not what we want, but if you carry this logic out and just focus on savings, sometimes it's cheaper to let people die early. So we want to focus not just on those dollar amounts, but on that health state change, the upper track up there. Have we improved people's health? And how do we then measure that? We can measure that directly in health terms. And that's cost effectiveness. We can measure that in qualities, quality adjusted life years. Those are preferences. There is a difference between qualities and quality of life. I saw somebody presenting on quality of life. Not all quality of life measures will let you get qualities. Qualities are not just quality of life, they're people's preferences for living in that quality of life. Right? This goes back to the consumer and how do you prefer? What level of health do you prefer? And we measure this at a societal level. And I'll talk about measures we can use to get qualities. But just because you've measured quality of life in your trial does not mean you can get to qualities. Right? I almost pulled this one out, but I thought it would be useful to show you one way to do cost effectiveness analysis. This is a decision tree. It's used in decision analytic modeling. And I did a hypothetical intervention. This intervention is actually was suggested more than once. So here's how this intervention works. We're at a primary care physician's office, and they're going to implement what I'll call an augmented SBI program. So they're going to screen for alcohol use and deliver a brief intervention for people who screen positive. And in addition to that, they're going to order some sort of augmented liver panel. I'll defer to the hepatologists in the audience what that should be. Let's just agree we're going to do something that we wouldn't normally have done. And we're going to do it for the people who screen positive for alcohol use, right? Now, out of that, we've got health states that can change. And I've kept these separated so we can think about sort of a staging, right? So people might reduce their alcohol use. And among the people who reduce their alcohol use, their liver panel might improve, their liver panel may have no change, or their liver panel may actually get worse. And each of those end states then carry costs and benefits that we can measure. And if we're really sophisticated, we can do modeling to get those over their entire life course, okay? All of that you see at the end of the little gray circles, dot, dot, dot. All of these continue out to the end of all of these paths, right? So even though somebody screened negative on our alcohol screen, they might actually be a false negative. They might be drinking in excess. And so then they can change their drinking or not change their drinking, and their liver panel can improve or not improve. So all of these carry all the way out. Now, this is one way we can do cost effectiveness analysis, and we can do this with just literature reviews based on existing evidence. There's lots of parameters we need to make this model work, right? What's the probability you screen positive? We can make this really complicated and look at false positives, false negatives, build in all the sensitivity and specificity into the model. Same thing with the liver functioning, costs, all of that we can get out in the literature, or we can build this into a trial, okay? So let's talk about what we need then to implement a model like that, right? One, we need those costs. What does the screening cost? What do the interventions cost? And this is where I want to make a recommendation. Don't save this for aim 3, right? When I was 20, I spent 20 years at RTI International, and as the economist, we would always get brought into somebody else's NIH grant. And we had our aim 3 text, because we were always aim 3, right? Aim one was usually, can we implement, develop, something like that. Aim two was, is it effective, efficacious, whatever. Aim three was, is it cost effective? Right? And we were given like one paragraph. Right? Oh, I need you to write up your methods and significance and innovation. And by the way, I need that in 3 sentences. Right? And we had a very tight budget. And we were always the first thing to get cut. Don't do that. Right? You yourselves talked about how important it is to establish cost effectiveness. You talked about how important it is to demonstrate healthcare savings, to demonstrate impact on revenue to the hospital system. Right? Now, you can't do everything in every study, but you can do the cost of the intervention. I promise you can, because you're going to do fidelity monitoring. If you're doing an implementation study, you're looking through to see who did what, when, where. That's a micro-costing study of the intervention. All you have to add to that is ask people, and how long did that take? Time. For most of these things, time is the critical element. Now we've got lab costs with the liver functioning, liver panels. Maybe there, you can just take whatever the Medicaid reimbursement rate is. That's what we tend to default to with things like tests, medications, right? We'll take some sort of Medicaid, Medicare reimbursement rate. There are other sources to get those costs. But if you're asking a practice to change its workflow, that impacts how people spend their time. Most people don't like to change the way they do things. When's the last time you got a software upgrade that completely changed the interface, right? And it drove you nuts. How long did it take you to adjust to that? If I ask you that question, you're probably going to say days. If I sit there with a stopwatch, we'll probably get it down to hours or minutes. And I learned that from real world experience. When the very first economic valuation of alcohol screening and brief intervention program I did, the study started in 1996. It was with Tom Babor and John Higgins-Biddle, the cutting back study. And we asked the nurses and the other healthcare providers who were doing the screening and brief intervention, how long does the screen take you to score? Right? That was done hard copy, paper and pencil in the waiting room by the patient. And we were just asking front office staff, how long does it take you to score this and enter into the medical record, which in that time was putting the sheet of paper in a folder, right? Their answer is 2 to 5 minutes, which seemed reasonable, except when we went to figure out how much does this cost, because if it was 5 minutes, it was more than double the cost if it was 2 minutes. And it's a universal screen. You're doing it on everybody. So we learned from that. And when we did the national cross-site evaluation of SAMHSA's SBIRT program and the second cohort, we actually did a time and motion study. We followed patients with a stopwatch. Yet screening doesn't take that long. But the problem is it's such a short activity. It was so perceptibly burdensome that people overestimated the time. And the margin of error made a huge impact on the cost. If it really is an hour-long intervention, 2 minutes on one side or 2 minutes on the other side doesn't matter that much on the cost. But screening and brief intervention is brief. In cutting back study, we got it down to 2 minutes for the brief intervention was 2 minutes. And it works. Right? That's the other thing to point out. I'm trying not to go too deep into effectiveness here and just stay focused on cost. But and Kathy Bradley mentioned this yesterday. Most people can change their drinking easily. People with AUD cannot, right? If it's a diagnosable disorder, they cannot. But most people who drink in excess of recommended guidelines can easily change their drinking. It doesn't take much to get them to change. All right, so do a micro-costing study of your interventions. Find out how much it's costing. Find out how burdensome it is to healthcare professionals you're asking to change. because that's the very first line you've got to convince. If we're going to anchor this in primary care, we've got to convince primary care that it's worth them doing. And the first way to do that is say, well, it's really not going to take that much of your time. And it's going to tie in really, the other thing I found is, yeah, I mean, you can sell it maybe to the administrator with revenue generation or healthcare savings. Primary care doc wants to know, is it going to help my patients? And they're not convinced it's going to. All right, the next thing, if we go back to Drummond's picture, we want to think about are those long-term cost savings. Right? Can we show that we're reducing future healthcare costs? Now that's important for the USPSTF, United States Preventive Services Task Force. It's important for government policymakers, Medicare, Medicaid, trying to implement this. As we've talked throughout this workshop, it has occurred to me and I know to others that saving one person money on healthcare is taking money out of the pocket of somebody else. And this has been a long-standing beef of mine with the way we do this. Right? If you prevent a market transaction, there's a winner and a loser. I don't spend money, but somebody else doesn't get money. That will always be the case with healthcare cost savings. Somewhere there's a doctor, a hospital system, an insurance company, and I know it's bloated. I know there's a lot of administrative costs in there. But somewhere there's somebody putting food on their table by being a healthcare administrator. Right? Think about your decision maker perspective. Whose costs are you saving? Who's footing the bill? For general societal impact, yeah, we want to look at healthcare cost savings, and preventing one transplant can pay for a lot of audit fees. All right, it's worth it. The problem is there's no societal actor for that. Medic services, the Center for Medicaid and Medicare Services, maybe, right? They're willing to make that investment. How would they make that investment? They would require it to be done, and they haven't gone there yet. They're incentivizing it by, yes, there is a reimbursement code. And Joe, before I started, said he wanted me to talk a little bit about my perspectives, having done this for lots of different agencies. I was briefly, as in one meeting, invited to attend the task force meeting on putting together the HCPCS reimbursement codes for Medicaid reimbursement of screening and brief intervention. I don't know why I wasn't invited back, but I have a suspicion. And my suspicion is my parting comment in the meeting was, whatever you do, make sure screening is not reimbursed separately. I didn't use the phrase unfunded mandate, but I wish I had. Alcohol screening should just be an expected part of a medical visit. And Medicaid should have said, and if you don't do it, we're going to pay you less. Now, behaviorally, pay you less, pay you more, you would think it doesn't really matter if it's the same amount of money, but it makes a big difference. Right? It was setting up a different perspective. And then the other thing I said was, and brief intervention is not a specialty code, it's a medical code. And we've touched on that as well, right? We can't have people who aren't in Ohio because we're not licensed. There are different licensure and reimbursement issues with being a specialty code than a medical code. All right, so I've completely gone off track. My apologies. All right, so look at long-term cost savings. We need to do that through what, Stacy and Kathy and others are able to do with medical claims billing, EHRs. We've got lots of good administrative data that we can tap into. The lawyers usually don't like us to tap into them, but we can fight those battles and we can get that done. All right. I'm going to move on. So the next step So that's all costs, right? The cost of the intervention, micro costing, future healthcare cost savings or additional cost burden. We'll do that through claims analysis or EHR analysis. The next thing that I, as a health economist, need you to tell me, what are the outcomes? Right? I can talk to you about what are the costs, and I can tell you, here's how you measure costs. And I can tell you, look, I want it not just in dollars, I want it in time and space and actual resources. But now I need you to tell me, and what are those health outcomes then that we're going to change? On the alcohol use side, we've got lots of options here, right? Remember my decision tree. I needed discrete health states. What are the drinking health states we want to look at? We could do the WHO risk levels, and those were mentioned. Low risk, moderate risk, high risk, very high risk. And those are based entirely on consumption. For liver disease, that might be the best bet. And we need a hepatologist to tell us, right? We've got various drinking guidelines. The CDC and NIAAA each have their own, depending on whether you want to call it heavy drinking, risky drinking. The terms are all over the board. The USDA has drinking guidelines. That's the Department of Agriculture. They're in our national dietary guidelines. No more than 1 drink per day for women, no more than 2 drinks per day for men. And they argued over those because there was a big contingent in the expert panel that wanted it just to be 1 drink per day. No difference for gender. And they did big systematic reviews to find out the risk levels. And then they got, I'll be honest, usually a bunch of old white men in a room to argue over what's our recommendation. And they argued a lot about that. Importantly, you don't get to carry it forward. I don't drink my drink today, I don't get 2 tomorrow, right? It's 1 per day. You don't carry them forward. Then we have, yes, ICD-11 is out. I'm a big fan of this. I was at WHO meetings late last year, earlier this year on their global alcohol strategy. And I heard a presentation on it. It codifies hazardous drinking, which is above guidelines, but without any real current psychosocial or physical harms. And that's not a diagnosable disorder. That is a health behavior to be monitored, but could get a code for it. There's harmful drinking, which is a diagnosable disorder. And that is roughly analogous to our old concept of alcohol abuse. You're experiencing psychosocial harms or physical harms of some sort, and yet continue to drink. And then you have dependence, which has all the physical dependence and some of the psychosocial dependence, withdrawal, tolerance, craving, continuing to drink despite problems. And we've got DSM-5, and we've heard a lot about that, AUD. I will ask you, please, as the economist, if you use the term alcohol use disorder, please be sure you mean DSM-5 AUD. Don't lump all of these as alcohol use disorders. We've got to get clear in our nomenclature. And finally, and then you'll see this under the liver functioning as well, people have thought about these things. And I'm on the alcohol measures for alcohol brief intervention trials. I'm one of the people who's thought about them. Now, fortunately, I was the only old white man in the room for that. So we did I think a pretty good job on the orbital, the core outcome set for our alcohol brief intervention trials. That's published. It's in the Journal of Studies on Alcohol and Drugs. It's the recommendation for outcomes, not just concepts, but actual measures to use when you're doing an alcohol brief intervention trial. Right? There's one, I have references at the end if you're interested. So there's one of those, there's a core outcome set that I found for non-alcoholic, help me here, steatohepatitis. That, NASH, right? Now, I mean, these things are changing, right? And these are a snapshot in time. This is what the field says you should measure. The advantage of these is that everybody measures these this way, then the meta-analyses are much easier to do and much more powerful. And synthesizing the evidence across studies becomes much more important. And for us, we don't have to go out and debate it ourselves, because I'll tell you, having done a core outcome set, I will never do one again. It is not an easy process, right? A systematic review with 1,500 studies. That's after we excluded, right? That was 1,500 we had to read. Okay, is not fun. All right, so we have those core outcome sets. On liver functioning, you notice I put non-alcoholic fatty liver disease up here. And I've had this conversation with a few of the hepatologists, well, and non-hepatologists. So only one economist was involved in the conversations. But alcohol is a problem for any liver disease, even if alcohol didn't cause the liver disease. Right? Maybe we want to expand our thinking. If we're going to, and this comes back to what intervention are we doing? And what's the primary endpoint? Is this an alcohol intervention that's looking at liver disease? Is it a liver disease intervention that's looking at alcohol? Is it a alcohol and liver disease intervention? You would think that wouldn't matter, but it does when you go out to that decision tree and the ordering of the arms and how do you combine them? Which brings me to joint alcohol liver states. Right. We've got alcohol-related liver disease, and that is a joint health state. Right. Some of the health states we want to look at, or maybe want to look at, actually aren't disease states, they're health behavior states. Being a moderate drinker on the WHO risk levels is not a disease. It's just a health behavior. And that has implications for how we think about quality adjusted life years. And exhibiting that health behavior while having alcohol-related liver disease is a joint health state. I've been doing some work on how do we put together these joint health states. The easiest way is define it now. Define that state, the joint combination of health behavior or AUD and liver disease, however you want to define those now. And then in your studies, in your trials, ask the right questions so we can understand what are the implications of living in that joint health state. Because what you find when you go out to the literature to look for quality adjusted life year information, and particularly if you're going to wind up going to existing surveys, the NIAAA-3 asks the SF-12, from which you can get the SF-6D, and I've done some work on quality weights, right? What is the health utility of living with current AUD, of living with past AUD but not current, of these health behaviors, right? If you want to look at those and you go to some existing study, almost certainly you're only going to get one of your health states. You may be able to get the health utility of living with alcohol-related liver disease, but will that condition on being a moderate drinker? Will that condition on having AUD? From what I've heard here, probably conditioning on AUD, because it sounds like a lot of people with alcohol-related liver disease had AUD at least at some point in their life. I think the prevalence estimate I saw was around 80% on one slide. Right? But do you know if they're in remission, in recovery from AUD? If they are, is that our current working definition of recovery, or is that an old definition of recovery? Right? Define these health states, and then let's measure what we need to get qualities. Now, again, I opened up by saying qualities are not quality of life. They're related, but they're different. We have several ways of measuring qualities. Again, what you need is a quality of life scale that then somebody has gone out and done what's called a stated preference exercise to find out how do people prefer these health states, rank them. Right? In health utilities, which is what we're measuring here, 0 is conceptually dead, and 1 is conceptually perfect health. Nobody lives at 1. Nobody lives at 0 either, but they're dead. It is possible to live at negative. So there are states that are worse than death. Okay. At least there are in the EQ5D, but the EQ5D doesn't get you up closer to 1. SF6D, you never see anybody negative, but you'll get people up closer to 1. There are floor and ceiling effects with these. The one that I'm currently suggesting we go with is proper, and I heard the timer. I'm going to wrap up. Proper comes from the NIH Promise quality of life scale. It's what we recommended. What we recommended Promise is the quality of life scale in the orbital core outcome set. It makes sure if you do Promise that you get the questions you need for proper. There are lots of disease-specific quality of life scales out there. Most of them do not have a health utility ways to let you get to qualities. So think long and hard before you pick a disease-specific quality of life scale and make sure you can get to quality adjusted life years. The other thing we need are the transition probabilities. We got to start following people over time. So we know if you leave the clinic with a positive liver screen and a positive alcohol screen, what's the probability next year you're going to be in that same condition or a better condition or a worse condition? So recommendations, micro-costing approaches to document implementation costs and other short-term costs. That you can do right now. Long-term cost measures should focus on additional healthcare costs incurred or saved. You probably can do that, particularly if you have access to EHR or other administrative databases. Measures of short-term outcomes should be derived from current core outcome sets. So find a core outcome set and use it. We need predefined discrete health states, and we need you all to come up with those. The economists will do it, trust me. We'll make assumptions, we'll make the model work, but you're not going to like what you get out of it. All right. Long-term outcomes need to include quality adjusted life years. Make sure you use a good measure for that. And then we've got to get these probability of transition between health states. There are existing transition models out there for liver disease, for alcohol use. This is doable, but a lot of assumptions go into making those models work if the real data hasn't been collected. I promised you references. The
right? Where my clinic started, right? Breast cancer, colon cancer. And I feel like, I think Dr. Sengupta gave a really good way of like looking at it, identifying the problem, really marketing when you're talking about how do you bring people like that you have this. Like one of the main inventions, even going back to the previous question of screening, there's so many different guidelines from different societies throughout the world on who should get liver cancer screening. And it's really still not streamlined. So I think like societal input is really important to say that screening is important and multidisciplinary care is important. That's where cancer moved to, and that's where transplant moved to, right? And I think implementing these clinics too, when these big hospital systems have these satellite clinics, is what you're saying, is knowing that you may be able to do it in those satellite locations, which we do. We actually go out to the community, like I will go with my surgeon to a community practice with an oncologist, and only if they need transplant, they come to our main center. So there are kind of ways to do that and still be multidisciplinary and still get patients in. But I think the key aspect for AED from everything I hear is we're missing screening, right? And so I don't know what, how to get that better other than just keep saying it, I guess.
Okay, Jessica?
Hopefully a really quick question. I was going to ask, like, how would you do a cost effectiveness or benefit analysis in an ALD clinic, asking for a friend? But I'll talk to you later. In terms of long-term, cost benefit, cost effectiveness analyses, how do we handle it if we want to model out past 6 months, a year, when we're looking at lifetime? And I mean, human behavior isn't linear, and often the, improvement in liver disease, improvement in symptoms is also not linear, and you can go into and out of different health states throughout a lifetime. How do we handle that when we're thinking about modeling these types of things longer term?
Well, the key is modeling, right? And you said that. There are several types of models we can do. The easiest one, and that's why I talked about the transition probabilities, would be a Markov model. We have these discrete states, and in a cohort of people go through the states, right? And you always have, or you should always have, the death as one of the states. So that's the absorbing state. And once all of your cohort gets there, your model is done. There are more complicated models that I think we probably want for here, and the discrete event states are kind of like a Markov, but you track individuals, hypothetical individuals through the model. So then you can allow for the probability of moving from, say, fibrosis with heavy drinking to fibrosis with moderate drinking, or et cetera. Those can change with age, with other characteristics of the individual, and it gets you a lot more detail. Some of them are very interesting approaches that require a lot more data and would really need, well, the people working in these areas do get NIH funding, and I know of a few NIAAA funded studies, would be an agent-based model where you actually let the people, your hypothetical people, interact with each other. And that would be really interesting if we start thinking about alcohol's harms to others and bringing in the spouses and families of the people with ALD and allowing that interaction. Those typically are more used in like communicable diseases where you need to know, it's hypothetical person 1, close hypothetical person 2, and how does the disease spread? Those are beyond my expertise, I'll just be honest. But those have a lot of potential, I think, as we start thinking about much more nuanced models of disease progression. But at the end of the day, those are all models, right? Those are all things based on the assumptions, and we can make the assumptions very complicated and relatively relaxed, but they are still going to be based on assumptions. So ultimately what we need are registries. We've got to follow the patients, and we've got to observe that. And that's not going to help us now because we're going to get that information 10 or 20 years from now. But you'll never have it if you don't start doing it. So we need more of these registry studies to follow these cohorts for a long term and really understand how do these things progress.
It's just a quick comment, very much in line with yours, because I think for early detection, we have this limitation that by far, most of the ALD studies have been done in decompensated and cirrhosis patients. So we really have, limited evidence for the natural history in those progressing from minimal or no fibrosis to severe fibrosis, right? We don't know like the competing risk, the health state, the quality of life, etc. And I mean, these models are only, as good as the data you put into them. So it's just a urgence that we really need to do these type of natural history studies, including in the very early disease patients.
Where did Sumit go? What's that? Oh. Maybe he went to the airport.
DJ, can I ask one quick question while we're waiting for Sumi?
Go good. Yes,
Um,
thanks.
So just in line with what Maya was saying too, can you comment maybe on distributional cost effectiveness and the kind of inclusion of socioeconomic disparities and race and ethnicity, which we know impacts, development of ALD, alcohol use, or all of this in those types of models, and who benefits using that?
I probably should say no, I cannot comment on that, but I will attempt an answer. I mean, it goes back to what Maya said. I mean, all of the modeling is only as good as the data that support the assumptions. And again, Markov models are sort of the easiest to implement, right? I mean, it requires the fewest parameters, and as long as you have some sort of data set you can calibrate against, if you want to, you just make up parameters until you match your calibration data set, right? And there are complicated ways of doing that sound fancy, but at the end of the day, that's all you're doing. It's making up parameters and matching a calibration data set. That kind of model, which is dominant, just does not allow you to look at race, ethnicity, age. And then again, and we can relax that because with say the NIAAA or the NISDA or some of these large cross-sectional data sets, we can look at race and ethnicity and age cohorts. But then you get into issues of, gender, LGBTQ plus, and, do we have data on that? And that's really important. I mean, we saw that with the Planned Parenthood example that, trying to understand, what are the drinking guidelines for people on, hormone therapy. We just, to echo what Maya said, right? We need more data, right? And we've got to start understanding those issues now. I mean, I do some modeling work, and I've got a student doing a Markov model for adolescent drinking trajectories. And the best we can do is the data we have, and those were collected years ago. We're using the National Longitudinal Survey of Youth in '97, right? These kids were born before my doctoral student was. And, but you need a longitudinal data set that asks alcohol use the same way every year for 20 years. We need more of those data. I think it's going to get easier. I also have a colleague who does cell phone mobility data. He can get real time, as in yesterday, as in an hour ago, data on where millions of people were. Right now, it's kind of scary to think that I'm probably in his data set right now. Right now, he can't identify me in the data he's got, but somebody can. Right. We start matching that with alcohol sales data, right? We know alcohol use is way underreported. Yeah, there are problems, sales doesn't mean consumption, and the pattern of consumption is important, I think, right? It matters. So I buy my alcohol once a week. Do I drink the 6-pack all in one night, or do I drink it one a night and then take a night off, right? That's two very different patterns. But I think there's a lot of data out there that we're not using. We're out of time.
Let's move on. So Thank you both. Kind of thoughtful enough to put some thoughts together from all of the talks, and we'll again use it as a forum for some interaction. Again, recognizing though that we want to finish on time.
Right, so this is the attempt at sort of summarizing the last day and a half, or, if your kids ask you like, what you did, just send them this slide deck and then email them or whatever. So, the goals, and we'll walk through it, and I tried to capture sort of the 9 sort of takeaways, and then, hopefully this will come into the document that we all put together. And so now's the time to sort of, provide feedback on the themes that were presented. So just a reminder, the goal was to explore the barriers to earlier detection and intervention for AUD and ALD, identify the necessary improvements and protocols and tools, and hopefully recommend at least a path forward. And the goal of, on behalf of NIH is to support research that provides evidence that may ultimately inform clinical practice. Themes that came out was that, we're sort of thinking about 2 diseases, 2 spectrums, and, where do our patients lie on the spectrum with regards to intervention. The second theme that came out from the morning session was, what is the burden of ALD? This is increasing, we're diagnosing it at a later stage, limited therapies, and certain demographics are at higher risk. And then the second part was that the earlier intervention is what would happen. Cost-effective strategies are needed, and a targeted approach is needed to identify high-risk individuals. And we also understood perspectives and gaps from primary care and addiction medicine. There was a thought on barriers to treatment, so this overlap between stigma, the complex symptoms of addiction, and limited accessibility, and some thoughts shared on how to overcome these barriers, both from a provider, patient, and system standpoint. So some of the recommendations now going forward, if, for discussion, and I'll pause after each of them, the 8 or 9, is one is sort of, implying recommending the use more strategically of Audit C, and potentially, monitoring with LFTs also to provide feedback. Thoughts on role of?
Yeah, good. So comments, thoughts, like, well, what's the current state? Do we have a sense of, is it already a guideline to some level that's just not being followed, or do we need to adjust guidelines? Yeah, thanks. George.
So I've been unrelenting in getting and torturing all of my fellow IC directors by getting the Audit C put in every cohort that I ever hear about. Laura has gotten it into the All of Us cohort, and David Goldman, our clinical director, on his own initiative now screens with the Audit C every patient that comes into the NIH Clinical Center in Building 10. So there's not a mandate, but there's a NIAAA is pushing this as far as we can push it. You guys can, and ladies can do the same thing.
Marina.
Press the button.
I think we have resource constrained settings, so I still think we need to study whom to screen if we don't know what we're going to do with the results. So yes, I'm in favor of screening, but we're not able to do everything for everyone, and I think we need to study it better.
So what I was going to say is that the Audit C is recommended by the U.S. Preventive Services Task Force for screening for adults. So they are saying, yes, please use this, as well as the NIAAA single item screener. At the same time, we know that even though the rates of screening are relatively high, and this is in Carrie Mintz's publication using NISDA data, most healthcare professionals are not using evidence-based methods to screen. So a lot of folks are still using the cage. They're still using, understandably, questions that they make up depending on where they practice. So we really want to see the Audit C or the single item screener used more.
And then Sumit, for your LFTs, you have data, you and Ray around I think it was an ALT, right? Where did that go in terms of becoming just a, part of the screening for everybody?
Dr. Bradley shared some data about audit C and the correlation with the transaminases. But that's something I think we should then recommend as like a research thing to see, does it correlate with outcomes and screening? The second part was, there was a discussion about, who to screen for asymptomatic ALD. And that I think, will go hopefully in the text of, identifying groups as we go back and forth. We may not be able to coalesce right now. But the second sort of, takeaway was to really emphasize the focus on role of brief intervention and developed and test interventions across the range of severity, integrate comorbidity into intervention design, and sort of, address broad health system integration. And then just a couple of sort of, slides on brief interventions. We heard about, a framework to do this across the spectrum of patients that you see that we see in clinic, and then also a framework suggested for patients with ALD. And I'll stop there.
Comments, thoughts on brief interventions? I mean, yeah, anyone want to comment on this? Especially maybe from the liver side, probably it's a little bit more, something that, I don't know, Tiffany, do you feel comfortable to be able to try to do this when you're in the clinic? Stacey had a comment. Yeah.
Well, I just develop and test interventions. I mean, I think there's a pretty robust evidence base on the efficacy and effectiveness of brief interventions across, we know that it works well with people with lower severity alcohol problem, unhealthy drinking, or however hazardous. Maybe not so much with for people with AUDs. So I mean, I don't know if that much more testing of interventions unless they're specific, say, to an ALD population.
Yeah, maybe training. I know, Tiffany, go ahead.
Oh, right. I was going to comment on that. I feel like after the past 2 days, I do feel more comfortable being able to implement that, but I do think as a training voice in the room, it does start at that level, whether it's in medical school or residency, once we get into the clinical practice model.
I think there's value probably in studying interventions with people with abnormal LFTs. So I don't think we know how much it takes and in what populations. The other opportunity I just wanted to call out, because when you say all patients, that's kind of universal. Are we talking primary care? Are we talking specialty? Are we talking everybody? And one opportunity I think is that there are some large FQHC networks in this country that function almost as closed systems because people don't have access to other sources of care that you could take what's been done in Kaiser and in the VA and test it in these large FQHC, federally qualified health center networks. And I think that's an opportunity to study prevention.
So one quick comment. I'm going to put Laura Quacco on the spot. But we launched last year the Healthcare Professional Core Resource on alcohol. And there's a whole section, one of the whole components in there is on screening and brief intervention. But I want everyone to be aware that this exists. It's everything you ever wanted to know about alcohol. Laura?
So actually, George, we launched almost 2 years ago, if you can believe it. I know, time flies. Time flies when you're done with creating that. So for those of you who don't know, the Healthcare Professionals Core Resource on Alcohol is it's a website. It's essentially, as George said, sort of a one-stop shop of everything we think healthcare professionals need to know about alcohol. It has 14 brief topics. These were meant to be consumed by busy healthcare professionals. Many of the folks in this room contributed to developing the content and reviewing the content. You also get free CME credit. Just putting that out there for physicians and psychologists and nurses and pharmacists. And I'm missing one. This is a living document, so we will be updating it periodically, as needed with new evidence and recommendations. But it includes foundational information on basic alcohol information, on stigma, neuroscience. As George said, we have a whole kind of set of topics on SBIRT, there's a screening topic and a brief intervention topic. We also have a slight reorganization, or I guess it's more like a primer on how do you really do screening well, and brief intervention is sort of step-by-step walking through. So that, like if I had to say, go to one page on that website, go there, like click on it and say like, okay, I've asked someone about their drinking. Now what do I do? You know, and it really clearly walks you through, but it's, I'm biased because I worked on it. I think it's a fantastic resource. I have to give a shout out to my colleagues, Ray Litton and Maureen Gardner, who really did a lot of heavy lifting in writing this, but it's a quality product. Again, free CMEs. You can come back to it time and again. It's a really useful thing.
Can I
Why
just
don't
ask
we
if
do,
there's
more comments?
MOC
So,
also?
actually, several hands, sorry. So comment in the back first, and then Scott, then Michael. Can hear.
And I do think that especially for the hepatology patients who show up with alcoholic liver disease, most of these folks probably have alcohol use disorder. So most of the folks in liver clinic likely have alcohol use disorder, where it's probably not just sufficient to do the SBI part. And so thinking about treatment, but one treatment to really emphasize potentially as clinicians and physicians is really medication treatment. So medication first, we thought a lot about this in the opioid use disorder world, but thinking about medication first, you know, in a hepatology clinic, especially for patients with AUD, not just stopping at brief intervention, referral to treatment, which we know there's lots of challenges.
Then Scott, then Mike.
Mine's just a logistic question. You mentioned there's CME. Is there also MOCs for that? Oh, so that's the new, well, at least one of the coin of the realm. So a maintenance of certification that we all need for ABIM certification. So I think there are different requirements that are, you know, questions that you have to answer rather than just passive learning attendance. So that'd be helpful. And maybe you can transition it. It would be very helpful. Thanks.
I'd just like to reiterate a point I made yesterday, which is that at least in the state of Wisconsin, much of the primary care and indeed the clinical care and gastroenterology practices is now being provided by nurse practitioners and physician assistants. So gastroenterologists are spending their time doing colonoscopy. And so much of the clinical work is with nurse practitioners and physician assistants. And a lot of the work in the emergency rooms, we get called by, through our access center, it'll be a nurse practitioner that's calling. So in giving this instructional development, we should include nurse practitioners and physicians assistants as well as MDs and DOs.
I'll go to the Latin.
I'm sorry, I just wanted to convey two things. One was I agree 100% about the issue of the stages in which we want to engage in active treatment. And there are within even the hepatology setting opportunities for brief interventions for individuals who may not be at the end stage of liver disease or further along with alcohol. Rather, they have conditions or comorbidities with other types of liver disease. And that hasn't been tested. And the second thing is this medication use and those individuals who actually are further stage and to just be able to recognize and initiate is also really critical where that brief intervention will not work. So I think there's very much room for testing and treatment in these, not to mention settings, for example, the vulnerable populations that I was sharing. We have no idea how things will work in that setting.
So then this sort of ties into, like, even Anjana had a slide on the natural history of liver disease and where to intervene. So the third message would be what you just described also is, you know, we tailor our interventions based on the stage of ALD and AUD, and that would be a recommendation and maybe a figure on that. Did you comment, G?
Oh.
Did you have a comment?
Yeah,
G?
yeah. Well, I agree with medications for AUD, but there's only one clinical trial, one prospective clinical trial in patients with advanced liver disease in cirrhosis from baclofen. So where's the data for that? You know, we need data if we're going to, use that practice routinely. I mean, I do it, but it's off-label oftentimes, and there's just no data, right? So there's a need there. There's a gap.
I had just a comment. We know that
alcohol adds to other liver disease and essentially makes all other liver disease worse. And there's a recent research letter out in Hepatology Communications that show that hepatologists are very bad at bringing up alcohol, screening for alcohol, as well as offering a brief intervention. And so I think that AASLD maybe needs to just remind everyone to ask about alcohol, and most of our patients that have hepatitis C or hepatitis B, they don't have alcohol use disorder, but they having that reminder is something that we can do better at.
So Hannah,
Sorry,
could it?
I just signed up to meet with them in the fall, so duly noted.
Sorry, I would say in the right or left side of the slide where you talk about early stage ALD, we may want to be putting a slash as an alcohol as a comorbidity with pre-existing liver disease, and to add on there the Hep GI clinics as well at the bottom part, because we really should be engaging in brief interventions in that type of a setting.
And then I'll move on.
Could I,
Oh, okay.
To me, tailoring is important, but to me, stepped care approach would also be appropriate here because sometimes you don't know if somebody can respond to a brief intervention. They're not reporting symptoms, but then they can't. So I would actually add a stepped care that we need to test, iterative interventions where you don't necessarily do meds the first time, but you might on the second or third visit.
I just wanted to mention in terms of training the workforce and nurse practitioners and nurses and PAs and social workers, there are different excellent curricula out there. So NORC at University of Chicago produces, they have focused on training nurses, social workers, pharmacists, and so forth. And so, you don't have to start anew with training there.
So maybe
Great
the
research.
other thing that we can also in the document summarize, what are the curriculums available? What's the NIH resources available that's been done?
Kathy, I just wanted to comment on the stepped care intervention that you were mentioning. Within the that depends within the context of what we are dealing with. Within the context of liver disease, when you're dealing with more advanced stages of disease and also heavy alcohol use, within that process of a stepped care, you will lose those patients, and you have to be able to distinguish when to really initiate the treatment with medication, more higher level. Whereas with areas where there's not as much severity, so moderate disease, you will be able to transition the patients, and sometimes you don't need at all anything. You'd be done with the step care, with the first step. So I think our study hopefully will show how that pans out within the context of different stages of alcohol consumption. But
I
that's my
totally
caution.
agree. I meant the early stage, honestly. I was leaving the late stage to you guys. I was thinking prevention.
We talked about a potential framework for early detection. And so, we would maybe potentially, recommend a version of this in the document that we, put together. There was also maybe maybe I'll stop on this point and open up was, we have thresholds for alcohol use, and should we emphasize the importance of metabolic risk factors? And therefore, should we consider new thresholds for alcohol use based on some of the data that Brian Lee presented?
I would absolutely, and I would say that in fact there are studies that are showing that even educating patients surrounding lifestyle modifications outside of alcohol use, which is exercise, healthy eating, has a significant effect on patients following provider recommendations. And so absolutely that should be considered, but also more holistic approach to both metabolic and alcohol use should also be considered.
And I don't think we necessarily need to get into a huge debate in the paper on this topic, but I don't know that I fully agree with the way that Met ALD is defined. It's defined as any one metabolic complication plus, this variation in alcohol that we talk about, and hypertension, hypertriglyceridemia, dyslipidemia are included in that, which can be caused by heavy alcohol use and then regress when you stop. And so certainly, is that a metabolic complication of alcohol? maybe, but would we consider people who just had alcohol-induced hypertension, who just had alcohol-induced dyslipidemia to be in a category of metabolic liver disease? I don't know. And so I think there are some questions yet to be answered about the whole Met ALD thing and the diagnosis and whether that, morphs over time into a different way of categorizing those patients who have, who have alcohol use. But
So again, on the same line, I think it would be a pity to stand, very strongly up against the new nomenclature for steatotic liver disease, just because the process was so long and so hard to get to. Now we have a nomenclature on these between EASL, ASLD, and APASL. No, sorry, not APASL, LA. So what could be done within the steatotic liver disease framework is just to consider liver disease patients who consume alcohol, because then you don't need to worry about classes. There will be plenty of people in the MASLD class who consume alcohol at an amount that actually harms their liver. So we don't call it alcohol-related liver disease, but we do acknowledge that alcohol is a contributing factor.
Marina?
Very quickly, not for the paper unless it's pertinent, but some of us here actually study liver outcomes, and for us, non-alcohol associated and alcohol are just all part of the same, risk factors that we studied. But as you know, with NIH, of course, we have different institutes. So we have NIDDK and NIAAA. And now that we've acknowledged this intersection, right, of metabolic dysfunction and alcohol, and we know that they lead to worse outcomes when they're, synergistic, we need to just think about creative strategies, perhaps for NIDDK and NIAAA also to intersect and think about large studies to fund this intersection.
Maybe 5 more minutes or to wrap up. Okay, so then going on to the fifth sort of recommendation that we would probably rally around is that, emphasizing the need for inclusivity in healthcare. We had discussions about rural and underserved, and also another talk on inclusivity and considering women and other minoritized populations. Recommendation sort of 6, this sort of, was referenced across multiple talks. And would this be one of our recommendations to study the impact of ALD in prevention in the framework of the social ecological model, and how to study that? Going on to last sort of 3 things is, discussion on considering various models of implementation for integrated care. And throughout this morning and yesterday afternoon, we heard of multiple examples of integrated care. We discussed barriers. And then this, I thought, was a good framework that was proposed, is should we suggest a framework for identifying, if our implementation is working? I'll stop there for a second. Sort of 7A, again, based on implementation, would be to sort of recommend expansion or consideration of the role of telehealth, but with the emphasis that, there are barriers in vulnerable population. And stop whenever.
Yeah, I'd say so we still have, payment model problems with telehealth across state lines, which is really unfortunate. With COVID, we took down all those barriers, but now they've all kind of come back again with states' rights. Yeah, but otherwise it was, I thought, yeah, it's a restriction.
I think we need to also measure patient-related experiences. It's missing completely from the expansion of a new modality of care delivery.
I guess it is a belated question to Dr. Kalili, but I remember your penetrance of access to telehealth or the videos in San Francisco area, even for the very impoverished, was 100%. I'm just wondering in this space, is there some value to trying to understand the penetrance of video capacity and telehealth capacity in this intersection of underserved and AUD nationally, particularly in the rural areas?
Then the other recommendation potentially would be to understand the role of integrated care teams in primary care. Dr. Zohar presented on this yesterday of, what's the target population and, possible telehealth as being an implementation thing, and also maybe integrated teams also being the theme that came up about implementation. Marina?
Very quickly, I don't think that this came up enough, but it did come up a little bit. Studying implementation techniques or implementation science, how to best implement given different populations, different settings, different resources, different team structures. I think thinking about that will be helpful.
I would just echo that we have so much data from decades of alcohol research that these, how they work, et cetera, that it would be a huge missed opportunity if we tried to kind of go back and demonstrate efficacy, et cetera, and not sort of jump ahead to, implementation strategies for what we know works in these other populations.
And then, some recommendation around, the need to invest in sort of, AUD treatment workforce and, how does that work out? Then there was discussion on future cares of looking at echo, telemedicine, e-consult, and, maybe a section on that. And then the last two slides, what was discussed this morning is, one is recommending examining costs across spectrum of screening, detection, and integrated care, and formally studying that. And here maybe also looking at sort of policies that have worked in Europe and Asia as an example. And then last slide, and then for discussion would be, what would we define as success in this field?
Patient-reported outcomes is missing there too.
To me, also joint outcomes. So quality of life in drinking or, health outcomes in drinking together, joint outcomes.
And I'll add something that's probably highly unpopular in the academic communities, but decreasing transplants should be our long-term goal to abolish them. So I think composites that include that.
I was going to actually say the same thing, but I was going to say it slightly more contradictorily, and because it's both decreasing transplants and increasing transplants, so that we heard both of them as being potential outcomes. One, that you decrease the transplants if you catch the persons early enough, and you convert the non-transplantable person with alcohol use disorder to a person whose alcohol use disorder no longer excludes them from a transplant, when that's the only treatment that will extend their life. It is a little bit difficult to be advocating the opposite things in the same paper, but I'm sure we can get around it. But so there's both decreasing and increasing.
Can I just say one thing? When we're talking about access to addiction, lack of addiction, medicine resources, would the NIAAA be interested in trainees, like certifying them in some kind of dual pathway? That's not an extra year necessarily. We already have many years and decrease in task force due to that. But some kind of specialization, I think, would be really helpful without too many, without it being too resource heavy.
Yes, I just want to.
We do have addiction medicine specialists and fellowships, and they're part of preventive medicine, as I understand it. And you can have people in the liver field become addiction medicine specialists, as well as people in psychiatry. So, I think there is a framework already for that.
Yeah, maybe formalizing it to integrate it more might be a pathway.
I'm a little surprised that the concept of harm reduction did not come up in this list, and it's something we really emphasized a lot yesterday, particularly the notion that patients think that if they can't stop drinking entirely, then they don't deserve treatment.
Good.
So I think that needs to be
Important.
reflected
Thank you.
somewhere in here.
Yeah.
One other thing that comes to mind is comorbidities within this context as well. We talked about metabolic, but there are also brain health, for example. Those are other types of comorbidities that should be a marker of success if addressed.
I wanted to say a word on increasing transplants and thinking about that, the vulnerable, so the patients who don't have the phones and are in rural areas. And I wanted to make sure somewhere it got in there that Medicaid covers phones, and that's not necessarily in all states, but it's in a lot of states. And so in our collaborative care trials, we've used where we can get people phones. So I just wanted to somewhere get that out there, that that is actually available for the underserved in some states.
Okay. Final comments? Any other comments from people? Well, I think that was a well orchestrated hour of freewheeling comments and brainstorming. Yeah, I think that was the intent, and gratitude to Sumit for providing, yeah, some structure to it. Yeah. And then remaining couple minutes, just to, again, finish on time. Maybe some of the NIAAA people want to make some comments as we start to wrap up. Patricia?
Hi, thanks. For those who don't know me, I'm Trish Powell. I'm the Deputy Director at NIAAA, and I have the pleasure, first of all, of just giving some thanks. I for sure want to thank the organizers, Vijay and Joe, for an amazing meeting. This has been really, really. Okay, sorry. I don't have the full list in front of me, but thank you so much to all who worked hard to put this together and to really cover the breadth of the issues that we need to deal with. From the title of the meeting, it seemed like it would be a little narrower, and this has been really informative too. I think George and I agreed. This has just been a fantastic meeting and covered a lot of the complexities that you're dealing with, especially in the heterogeneity of the systems in which you're working. I want to thank all the speakers and participants, everybody who made comments, everybody who gave fantastic talks. They were really, really good. I want to thank the NIAAA staff at the Division of Metabolism and Health Effects who worked hard on this. And thank our IT support, especially Chris, who was described by one speaker as our superhero on site. So thank you for that. And thanks to Bill for monitoring the Zoom and the chat and keeping that all together. And for Tim Hedges at NIAAA. One comment I wanted to make from the NIAAA perspective, I think times they are changing around alcohol. And I think a lot of you have expressed that. We've seen it. One of our major themes is changing the conversation around alcohol, because until we change that conversation, we're not going to make the progress that we all see that we need to make. George has done a lot of presentations with that as his theme. We've talked about it. We're thinking about it in a whole range of areas. We're appreciative of how many of you have been partners in changing this conversation. I think the talks have been reflective of that. You know, just one example, you know, Stacy, Sterling, and Kaiser, in terms of alcohol as a fifth vital sign, that's huge. We'd like to see that everywhere in the country. Really recognizing that alcohol is one of those main ingredients you need to know in order to treat a patient, and not just in liver health, but in many aspects of, many aspects of health. You know, one just quick anecdotal example, you know, you see an 80-year-old woman in the emergency room who's fallen multiple times. Is it frailty? Is it alcohol? You know, those kinds of considerations we really need to build into physicians' brains. And I think, as Laura pointed out, the healthcare professionals core resource was developed in large part to bring that to the attention of all people who provide healthcare, whether it be clinicians, pharmacists, nurse practitioners, et cetera, social workers, to really have alcohol as kind of a front and center. How does that factor into health and health at all stages? And so to that point, also, you know, we talk about cutoffs of screening and all, but getting beyond just alcohol use disorder. You know, as many of you mentioned, alcohol is really dangerous at any level for someone with a liver condition. It's also dangerous at any level for other conditions. It's also dangerous at low levels for various conditions, and really getting that message out that there's no healthy use of alcohol And also alcohol at many levels can be harmful depending on the individual and their health. And again, alcohol is a fifth vital sign. We give a clinician the opportunity to make those statements early on to prevent a lot of the things we've been talking about. And kudos to the hepatologists. We think that you all are leading the way in a lot of ways in terms of getting that message and also in terms of integrated care and recognizing the value of integrated care in really making the patient's life better. I put some notes, not necessarily that I can read my own writing. The other thing that was mentioned that I thought was really a good thought was if we could flip that conversation to not I'm taking something away from you, but I'm giving you a chance to have a healthy lifestyle that you may not have full advantage. If you change the conversation to, would you like to sleep better? Would you like to have more energy? Would you like to have a better quality of life rather than you can't drink? I think it's a very different message. I think, as George points out in a lot of his presentations, he likes to quote John Kelly, society has become inured to the harms of alcohol. We think it's so important for everything we do that we've kind of lost that. And so, again, just changing the conversation, the way we talk about this, may make a difference to a lot of people. And to that, I think movements like Sober Curious, Dry January and all have indicated that the conversation is changing and the stigma around not drinking is going down. So I think it's not just the stigma around drinking, but it's the stigma that I cannot drink and you don't think that there's something I should distance from that person from. And also I think that also reduces the stigma of AUD, not AUD, drinking at different levels. So NIAAA's role is to support your research and the research enterprise more broadly. We want to support research that informs the messages that are put out. As you mentioned, the clinical practices and also the policy. You know, we heard a lot of kind of tongue-in-cheek comments about we don't talk policy. We do talk policy. We do the research that informs policy. We just don't make the policy. So I just wanted to make that clear as well. We realize that a lot of policy type interventions are very effective. So with that, I want to thank all of you. This has been an amazing 2 days, day and a half, feels like 2 days. Thanks to everyone who participated. Thanks to everybody who put this together.